Hear me?
Yes, I can.
Okay, maybe Aaron stepped away?
I doubt it.
Oh, he's there. Okay, all right, so I think we got everybody hooked up. Perfect. Okay, so being 5:30, we'll call this,
Much anything.
we'll call this meeting to order. This is an ad hoc committee for medical advisory for the Waunakee Community School District. Is the recording ready? Great. And so, as a roll call for our first time, I think it'd be good if we just went around the room and introduced ourselves to each other. So I'll start. I'm David Betcher. I'm currently the president of the Waunakee Community School District Board. And on the phone, we have Dr. Walsh. Would you like to introduce yourself?
Sure. I'm Ellen Walsh. I'm the head of the Department of Pediatrics at the University of Wisconsin, and I also am an infectious disease specialist.
Thank you. Aaron?
I gotta follow that.
Yes.
I'm Aaron Salvato. I'm a teacher and I'm just a nerd who reads footnotes.
Valerie?
I'm Valerie Clevenger. I'm a physical therapist in the district.
And Dr. Anderson, would you like to go next?
Yeah, Matt Anderson. I'm a general internist at UW Health, and I work overseeing operations for primary care and urgent care for our system.
Bill Raynoff, family doctor here for 30 years.
Hi, I'm Sarah Anderson-Kim. I'm a family nurse practitioner currently working as a school nurse here in Waunakee.
Brian Grabarsky, Director of Human Resources.
Lauren Bellman, nurse practitioner at UW Health with working inpatient with vascular surgery for 15 years.
Jack Hangman, currently the treasurer of Waunakee School Board.
Jeff Hodoff, I'm an emergency medicine physician and serve as Ely Hills Chief Quality Officer.
I'm Kurt Ely, I'm the Director of Student Services for the district.
My name is Sarah Gaines. I'm a nurse practitioner with UW Infectious Disease and Infusion.
Yes.
Brian Hafer, Waunakee School Board.
And Randy Gutenberg, Superintendent Waunakee.
Hang on
School
one second. For those of you who...
During the meeting, you may have to tell me what they say.
Okay. For those of you who are on the phone, if you would like, if you go to the Waunakee Community School District and go to Board of Education, there is a live stream of this meeting going on right now. That will allow you to see people and maybe have a little better hearing. It's only a few seconds delayed, so it's not too bad, hopefully. And that might help with some of the volume issues. Okay, so I really appreciate everyone being here. I know we've been contacting some of you and asking you questions over the past couple months, and you've all provided good input to the district to help us try to figure out how to open up our schools, or if we can or should, or the safest way we can do some of these things under what are conditions that for most of us in the board and for in administration and in education have no idea what we're talking about. So having you here will be a great way to help us see some of the issues. And I think we've seen that everyone seems to be treating this virus, it's more local than it is a global. And so our biggest issue is how do we deal with it within our school district so that we aren't just trying to rely on a statewide number or a national number that really doesn't exactly help us on a day-to-day basis. And so that's why we've asked many of you to come here and try to help us figure out what are, we have metrics from Dane County now, thankfully, although that was just on Friday. But that doesn't exactly answer the case of if we start seeing some classrooms or students or staff having cases here in Waunakee, should we act faster or in a different way based on the very specifics of what's happening within our school district? And so we're hoping you can help us understand what some of these numbers mean and maybe disseminate down where should we be at our level as far as either opening up more or closing down more. And also trying to figure out a way, because everything I hear says rapid testing is the thing you need to have, and we don't know how to do that. So we're hoping you guys can help us with that too. So the first item, well, we have to approve the agenda, which I'm not sure on the policy of this. Does the whole committee approve the agenda or just the board members?
You could,
Probably the whole committee.
I would think so.
Our committee.
So we need a motion to approve the agenda, which I wrote and somebody else more competent should have. But again, we're just starting.
Motion to approve.
Is there a second?
Second.
Thank you. And any discussion? All those in favor of approving the agenda say aye.
Aye.
All those opposed? So we do get to have some formalities because it is a public board. The next thing I think Dr. Anderson brought up that we should make a very clear statement of, many of you are from organizations that you are not representing here. You are representing yourselves. And I think, Mr. Anderson, if you would mind saying kind of a statement that makes it clear to the public what you're doing.
Yeah, I think our intent, and others feel free to chime in, is that we don't represent the organization's position. The organizations that we work for may take a different position or may choose not to take a position. We're doing our best as individuals to bring clinical expertise to the discussion. And I just want to be clear that we're representing our individual opinions with that and not our employers.
I think we're all agreed on that. So the first item I put on was discussion of goals and agenda items for this committee. And in that, I put down, I kind of know what the board is looking for. We are looking for a little bit more specifics and metrics for what will happen within our individual schools. For example, Dane County has put out a number for when you can be open for K2, K through 5, or above that. But if we start having cases within one of our schools, should we be looking at a number specific to us to figure out if that school as a whole should close down, rather than just contact tracing closing down individuals or a classroom? The other side of that, of course, is how do you decide when to open up more? And again, maybe Dane County's number is enough for that, and maybe you can help us understand that, or maybe should we be looking at something even a little tighter to make sure we're dealing with our case specifically. The other thing I know the board is looking for a lot is about trying to get contact tracing. I'm sorry, not contact tracing, trying to get rapid testing of some degree. We have had some contact with Dr. Wald about that, who's been a great help in starting the conversation. And the other part was a discussion, and of course his name is escaping me now, about the testing with the spit test being a non-diagnostic test, but a possible pre-screening test we could be using. And maybe we can discuss that in the third, item 7, I had that down there. But I'd really like to hear from some of the medical people, what are we missing? What else should we be looking at strongly to make sure that we need to somehow figure out as we're opening our schools up and making sure the students and staff are as safe as possible?
David,
Yes.
before folks that are far away from the phone start talking, where did you say the stream was?
The video stream, it's on, if you go to the Waunakee Community School District, you go to Board of Education. On several of the pages, it talks about the YouTube channel. If you click on that, there's a current live stream of this meeting going on.
Rebecca, can you email them the URL, please?
According to YouTube.
Oh, I'm looking at myself speaking now. It's crazy.
No.
Rebecca will email it out to people.
Thank you.
So oh, yes. Dr. Wald?
Yeah, no, I said that would be great if you mailed it out.
Okay.
We'll make it, yeah.
She's emailing it out right now. So I'd be interested to hear from people on the committee what they think are items that we need to ensure that we go over. One other thing the board did bring up the other night was a concept of face coverings. There's been some discussion that some face coverings are inadequate, even though they fit within Dane County's definition possibly, and they'd be interested in hearing from you all, is there a better standard that we should consider to use?
Would it be helpful, Dave, for us to provide just a high-level overview of what we're doing so far? Or just to give you an idea of who's in, what programs we're able to support, what we're not able to do, and then some of the practices that we've got in place thus far, so we can provide some structure to that, feeding into as far as some of the other things that we might want to discuss.
Go ahead.
All right. Obviously, the order that came out on on Friday dictates the metrics that you find in your folder in front of you. They've broken it out by K through 2, of which we've already met that metric, so we're able to bring those students in. There's obviously pieces within the order that talk about social distancing, etc. In order for us to socially distance kids in the classroom, we're not able to bring all of our children back, so we've split it up into an AM-PM hybrid model. So that's really what that...
David, I can't hear this, and this is really important, and she didn't let us do that.
I'll move over here so you can hear.
That would be great,
Yep,
thank you.
is that better?
Yes.
All right,
Could you
awesome.
start from the beginning, though? Could you start from the beginning?
Oh, I can absolutely start at the beginning. We had, on Friday, we had the Public Health Medicine Dane County came out with their most recent order. In that order, they identified what we were able to do as a school district. Primarily, being able to bring back our K through 2 students. Within that parameter and those metrics which have already been met, we have certain parameters we have to follow with regards to social distancing of kids in the classroom, which doesn't allow us to bring our full capacity of our students back all at once. So our solution to that was a hybrid model that allows for an AM and a PM shift of students. So we're really looking at class sizes that range from generally around 12 kids, generally for AM and PM K2 students. The other piece we have is we have a virtual option for families. The order on Friday also has an additional metric for 3rd through 5th grade. We were initially going to bring back K4. The order on Friday has shifted our ability to do that. So our 3rd through 5th grade students will start in a virtual environment until their metric, which is outlined in front of you. We have to have the 14 days over 4 weeks metric come down to 39 cases. And once that is met, then public health will put forth a new order that would then allow 3rd through 5th grade back. The school board met on Monday, and what we've decided is that we will have, after that order comes out and we meet those metrics, we'll bring back our 3rd and 4th grade students first, because we already have a plan in place for them. So just hypothetically, if we met that metric sometime in mid-September, probably by the end of September, we'd be able to bring those children back. Our 5th grade in Waunakee, our 5th grade students are in our intermediate school, 5th through 6th grade. We had initially articulated to have those students back at the quarter. So if the metrics are still there, we'll bring back our 5th grade if that metric is there at the quarter period. The other grouping then by the order on Friday was from 6th grade through 12th grade, which following that same metric of the 14-day average over a 4-week period has to drop to 19 in order to bring those students back. So those students right now are going to be studying the year virtually, and then we'll be following the metrics moving forward to see how things fall as far as when we're able to service those students in person. So those are starting. So K2 in person with the hybrid AM and PM, 3rd through 12th grade starting off virtually. We've also had a few other things happening with our students. We've allowed for our low-risk sports to continue, but not travel. So they're not allowed to travel outside of Dane County. So that's golf, cross-country, and singles tennis, which are allowed by the order. We also have, as a board, approved any of the activities, even up at the middle and high level of sports, if they're allowed by WIAA, the organization that oversees sports in our state, to be able to meet for certain numbers of contact days in the fall. So most of our high contact sports are like football, volleyball, soccer have moved from a fall season to a spring season in an effort to see if we can possibly have activities in the spring. But there's going to be some contact days that the board has approved. It's like 6 days for students to come together in small groups, socially distanced for activity. And they would be kind of related to some of those sports. So soccer, football, I think volleyball, all have something in mind specifically of how they could do that. There's pretty strict rules around that. Inside you have to be narrowed down to 10 kids. Outside your groups can have to be a max of 25, socially distanced. We've had very good experience this summer with kids on the football field, distanced out across the hash parks, doing just basically agility type drills. We've been doing that since July, and that's gone very well. They have to socially distance, they have to do the health checks, etc. We would also utilize that same thing for some of our activities at the middle level to get kids active. And we are allowed by the order for some of these activities for sports related to bring kids in and socially distance them, keeping them in small groups. Primarily, these are all outside activities. So those are the things that we have going right now with students and instruction. The other pieces we've put in place, and I know, Dave, you have this on the discussion tonight, is face masks. That's obviously required across our county and our state. We certainly are enforcing that as well with all of our staff and our students. And then obviously needing to follow the protocols that public health has put out with regards to cleaning in our buildings, hand washing. We've added sanitizer, gel hand sanitizer within our buildings. We have some of the sanitary wipes for people to wipe down areas and access to those to wipe down areas where people are meeting. And then we've added pieces like the electrostatic sprayers to our custodial teams, as well as adding the electrostatic HVAC component. That will be a piece that we're putting into our K-4 buildings, as well as we'll be considering that for other buildings at a future board meeting. So those are kind of the pieces that we're doing. I know Kurt, you guys have been doing the trainings on the PPE with all of our staff. We have different videos that are being pushed out, and generally that's really our practices we're trying to do as far as instruction, what we're doing with kids and what we can do with kids, and then what are some of the basic components we're putting out into the schools. So let me at least give you a guide as far as where we're at.
Did anyone have any questions on that? Okay.
I apologize.
Yes.
As far as the teachers, are you screening out who you're going to allow to teach, or are you doing any, as far as risk-based for the teachers' risk levels?
As far as
Like whether somebody's 65 or 25,
yeah.
that type
Yeah,
of
Brian, I guess there's two things here. We also do a wellness check, where you can see the sheet that was in front of you tonight when you came in. We're utilizing those with our staff and our students. And our staff have an electronic check-in piece every morning with regards to that. And then with regards to, Bill, your question about how we're dealing with high-risk families, that's a piece that Brian has been very extensively involved with in the HR department.
Communicated to employees to let us know, to self-identify if they felt they were at risk due to their different factors, and then have worked with those individuals to, if possible, develop plans that allow them to either work virtually if the work permits, mitigate their risks if it doesn't permit, through either protective measures, perhaps reassignments, things of that nature.
Were there any other questions on kind of how we're basically set up right now?
It's a little bit different question, but outside of school, are you looking at other groups in the community that could potentially cohort your kids and then potentially put them at risk at bringing a bunch of kids back that could be positive? So I think of team sports would be the example. If we have soccer or other team sports happening, how are they setting that up? And are they doing it in a safe way so that the kids don't get infected, say at soccer, and then come back and all of a sudden you got a problem?
Right. Yeah, that's a great question. One of the things that we're having them do is they're putting together written plans for us for any of the groups that are getting together. So for example, the group that we've been working with, which is the strength and conditioning kids out on the football field, as they're arriving, they have masks on, they have to have their health check piece, they're lining up against the fence socially distanced, and then they're keeping socially distanced as they're on the activity. That activity, they were on like the 5-yard line markers. The kids did not have their mask on outside while they were doing the activity, but afterwards we were trying to maintain that, and then also keeping the kids separate so that they didn't mix. The other pieces I know that we also have going on in the community, we're working with Wisconsin Youth Company, who's done our after-school care. They are offering some extended child care provisions within our schools, because that is an exemption from in the order to allow certain experiences like delivery of food to families in need, distribution of materials to kids, but also child care needs. And so we have, at Heritage School, we've opened up some of our classrooms for them to provide some of the wraparound care for families who need them. As a service to families. There's also some staff taking advantage of that as well. And they are working to, obviously following the same parameters we are, where we're trying to the degree possible, cohort them and keep them from mixing as well. Is that kind of what you were getting at, Jeff?
Yep, all that stuff, community groups, just making sure we know where
Yeah.
risk is at. Sounds like you're confident.
Yeah,
Well, we're still aware that there are groups of kids going to form new teams, get out and play because high school's not happening. And so
Yeah,
that is something that's sort of out of our control in terms of we are trying to educate as much as we can.
Yeah, the things within our control, we're trying to follow those protocols, but we realize that there are kids traveling and doing other things that we can't necessarily have control over, but we realize that they're happening.
And cross country, we may have work competitions, so that it is social distance, and then we can stagger stuff because we've got electronic time. And kids are socially distanced, and they're doing a pretty good job.
Any other questions? Just so we have the same baseline. Okay, then our next kind of point was to try and figure out, and maybe we should almost do this at the end of the meeting, is to lay out, are there items that people in the community think we're going to need to look at in the future so that we know to get the research done to figure it out, so that we can bring it back to the committee so we can see what your recommendations might be. And I'm kind of hoping on your guys' expertise, since you've been running through this a lot longer than we have. What are the sort of things procedure-wise that you've been seeing that maybe we haven't, that we should start to consider to get ready for, if that makes sense? I mean, we all know about put hand sanitizer bottles at the front of the door, have them, fill out a slip of the screening test, the concept of having the masks available at the door for people who don't come with them. But what are other types of procedures that have been helpful that we maybe aren't doing yet or haven't considered to start doing?
So are you guys doing individual screening then? Is that the plan, is that each kid comes through and you're getting them? And are you starting it, I apologize for ignorance here, are you going to do it on the bus? I mean, as they enter the bus, or where are you doing it?
It's a good question.
We are not planning on doing it as they get on the bus. We talked about that. One of the things that's the challenge with that is, in order to do that, we would have, the bus driver can't do that, and be responsible for driving the bus. So we had talked about at one time to put bus attendants on the buses who would be equipped either to, all students are expected to come to school with this form filled out. If they don't come to school, when they arrive at school, arrive at the door, if they don't have that, we have contactless thermometers that a staff member will take the temperature. If the temperature is 100.4, less than 100.4, they will be allowed to go to class, but our health office staff will contact the parents and do a quick phone call screen to see if there was anything going on. If a student shows up at the door and some of these symptoms are checked, they will be taken to what we're designating as the isolation room, although we're not calling that because that's just not good. They will be taken to an area where our health office staff will then using the information on there, follow up with the parents to find out what may be going on, because I'm going to state the obvious here to all of our medical professionals. There's a variety of reasons people could be exhibiting these symptoms, asthma, allergies, the list goes on and on. So we're going to look in our database to see what information the parents have already shared with us to see if they've reported allergies or some other medical condition that could be a probable link to why these were checked. Then reach out to the parents, talk about that to find out if they believe that the symptom that they checked is directly attributable to a known non-communicable condition. If that's the case, then the student would be allowed to go to class. If we can't do that, or they think it may be to a communicable disease, then the parent would be asked to come and pick the child up immediately from school. And they would stay in that room until the parent came and picked them up. So going back to your bus piece, at this point we do not have that. We did talk about that. We're going to have very few kids on our buses that we feel we can have them on the buses socially distanced and be okay, because A, we're only bringing in K2s and some 4Ks, that the capacity of our buses are going to be such that we're going to be able to have students spaced seats and rows apart from each other, that we feel that's okay. As we continue to open up and we have more students riding the buses, that will be something that we're going to have to revisit, as well as monitor our routes to see if we're starting to reach that capacity, even with the few students that we're bringing in at this point in time. So that's how we're going to start at this point.
Okay, I don't mean to interrupt, but I just have to reconnect Dr. Walsh, so you'll be hearing the phone. But go ahead.
No, I just wanted to reiterate that we are encouraging parents that to the degree that they're able to drive their own children to school, to try to get our numbers on the bus down.
Because I don't know what the other sites, but just speaking from our work, what we're doing now is everybody is screened. 100% everybody is screened at first contact. Just 'cause, and again,
Try again.
It was screening them just, I mean, the university, if you said you don't want to be screened, you're not coming in. I mean, and I don't know how I'm not yelling at anybody, I just, your job is enormous. I just feel for you. Because how do you get that level of screening? And again, and I apologize for talking too much again, but it's like, I'm not so much worried about the kid, I'm worried about the bus driver, right?
Yeah.
In the setting of.
Well, when we had talked about that, that was when we were sort of opening K through 4, and we were sort of worried that we weren't finding probably a potential writer to take that responsibility away from. If we're only doing K2, is there an opportunity to have a writer on a bus to take those slips as they get on and make sure they
It's
get
possible. It's possible, sure.
Just because things have changed so drastically, that the numbers are lower, that there may be a volunteer or another bus driver that would normally drive a route that would be
Yeah, I think we'll be running our routes as normal, so I don't know. There may be a few less routes than we normally would run, but we still have to cover the whole district. And in that between when AM dismisses and PM starts, that's kind of a tight timeline to get everybody home and then to run the route again to pick everybody up. And I believe the bus company is intending to do some level of disinfecting between AM and PM, so that time shrinks a little more. So the number of routes we have to run is probably close to what we would normally.
I think the key point you're getting at, though, is where does screening occur? And so whether it's, because even there's an issue there if it's the door, because you really want to avoid having as many symptomatic people in your buildings as possible. And so you have the issue of when the student arrives at school, whether they were on the bus or not, they have the slip. They have to, notify somebody at that point, or else you're letting everybody in the door, and now you're having potentially other symptomatic. You'd like to think that symptomatic people are not coming, but it, could happen. And so then you have the issue of queuing, and where do people line up in the queue? in order to get in the door, and how does that process work? So one of the things that we've had to deal with, like at University Hospital, for example, is just how many people do you need at that point in time in order to complete your screening process? And if you have a symptomatic person, where do they go, and how do you minimize the transport through the building? You don't want them traipsing all the way across, at the high school, across the Commons cafeteria space, right, to get to that room, because then you figure out. So I mean, it's really it's pretty complicated when you think about it from that standpoint. And what do you do when somebody screens positive? The only other thing, sorry, I've thrown a lot out there. The only thing I'd say about the screening piece is that we found, I think one of the things might be missing is, have you tested positive? Have you been tested, and is a test pending? Because not all the patients all the kids are necessarily going to be symptomatic. And somebody could be, we've had instances where people get confused and they say, well, I have a test pending, but I don't think I have COVID. Is that somebody that the district wants, coming to school in the building versus, what happens to that child if and when they're coming in? So we ask about, have you tested positive? I think it's in the last 10 or 14 days. I can't remember exactly. Have you tested, or do you have a test pending with that? Or have you been in direct contact with somebody who's known COVID positive? Because that just precipitates some additional questions. So the screening part itself is actually pretty complicated.
So Matt, one of the things we're trying to do is just as you said, we don't want to have them walking all the way to the classroom to collect those.
Yeah.
We're looking at a process to do that at the door, so at the point of entry to the school. I mean, is it a piece that, as Bill brought up, should we be doing that at the entry to the bus?
Yeah.
And that's the piece that I think, a part of that is the staffing aspect with regards to bus driver being responsible for it, and two, just as part of what Brian has found, is just the ability to find that level of staffing to put people on all of our buses.
The other piece of it that we talked about is that if you have kids standing out for the bus, they're not necessarily with their parent, and if their parent didn't send them with the form and they haven't had their temperature taken, we could have somebody take their temperature, but really that parent needs to get a phone call to do the symptom screening if it's a kindergartner, and so I think that there was kind of a practicality issue, whereas when we're collecting it at the door to the school, the elementary schools have a plan to have 5 different entrances, so we're not having all the kids come in one door. Well, you're staffing 5 different entrances with different staff to help collect that, so we're not gathering everybody. And then, like Kurt said, if they haven't done the form at that time, we can do the screening there. But I think it has to take place with the parent, because the kid's going to be like, yeah, my nose is sniffly and I have a little bit of a cough. So it's hard to get that parent involvement when you're at the bus line.
I think that goes like one of your solutions is going to be upfront, where our families in the community know that this is the year where you really can't cheat on sending your kid to school sick. And don't make it that we catch your kid at the door with their slip that says they've had a fever. Like, that would not be the ideal process. We need to keep those kids home, phone ahead, kind of the current process for sick kids calling in. And really not have, hopefully decrease the number of kids that show up in our schools that have even mild symptoms, because that creates hassles for everything. It creates hassle for the school, it creates hassle for the parents who come get their kid now. It's just best if we don't get in that situation. It's good for our families to understand that.
I haven't seen the complete bus plan, and I have heard things about putting families together on the bus so that you're not having different families sitting next to each other, keeping the windows open when we're able to. So other ways to mitigate that risk for the next couple, for the first couple months, or now it's really hot, but.
And the other question is, do you do a self-monitoring approach? I mean, there gets to be, what level of trust is there? Because it becomes operationally almost impossible at some point to do it, keep it physically distanced, and do it really well. So do you implement some sort of a self-monitoring process and say, this is on you, as to Jeff's point, as parents, within the community, to keep each other and keep your kids safe, keep the teachers safe? So do you have the screening process where, if it's going to be that everybody's just going to walk in and turn these in and it's going to become impossible to actually look at them, do you have to say, we're trusting you, within this process, and then you have some other mechanism, maybe for you do a spot check one day or something like that to see where you're at? I guess that's the question operationally that would be out there.
And that's a conversation we did have, was by having to fill out the form, you have to at least be conscious and active and kind of going through those symptoms and sending your child. And that was a piece we felt was important as far as a parent having to actually put that piece forward and then send their child forward with that articulates that that's really what we're claiming. So it's kind of to your point.
Did they have to have a piece of paper to get on the bus? Is that their ticket onto the bus? My kids would have forgot it 3 times out of 5. I mean, they're just.
Yeah, right now our point of entry is the school, and it hasn't been the point of entry on the bus for exactly what Sarah said, because you have a number of kids who are.
I'm just saying, because they can't get it back, right? I've tracked my kids, been through this, like they leave something at my house.
Yeah.
Yeah.
How do I get it there? Now I guess you can take a picture of it and send it. I mean, there's
Yeah.
lots of ways to do it.
And I think that's what Kurt says, if somebody shows up without it, they forget it on the bus, then there's another mechanism that they're walking through at the school where they're gonna go to another line to be kind of assessed.
That makes sense.
And I think when you sit down and take a look at it, we're contracting our busing out. So I'm not sure that company wants to take that liability.
Oh, I'm sure they do.
To get the slips and all that kind of stuff. So we really have to have school employees or somebody that's an employee of the school collecting that. And, when you look at how the kids congregate for the bus pickup, mom and dad might have dropped them off at that corner because they know that there's other parents out there and so forth. And now you don't
Hey,
have
Aaron, is that right? I didn't touch you on speaker.
Sam can't get on the bus because he doesn't have the slip, and the parent isn't there.
I think 2 other things on screening. One, you educate your teachers that there are going to be the people who are more likely to catch these kids who are not feeling well. They're going to see them every day. They're going to kind of know what their normal is. And if they're not normal, it needs to be okay for them to speak up and say, hey, so-and-so is not okay today. And there's got to be a plan to then address that. The other thing I'll say is thermometer checks sound really good, but our experience with them is that they're actually not that useful. The IR thermometers have a hard time differentiating between what's typically low temperatures because of the ambient air temperature and a true fever. Although it sounds great that you're going to catch people with fevers by these IR thermometers, our experience is that you could easily have someone slip through with a fever because they just walked in from outside where it's 70 degrees. It's going to pull that forehead temperature down out of the fever range into what's normal range.
Especially true as the temps get colder, as you get into the fall, they're much less accurate.
So what percentage now are they saying are asymptomatic transfers?
Kids, they say about 40% of kids could be asymptomatic.
And we know a large percent of the adults that I've had test positive afterwards don't even remember the symptoms. So, including in the families that have had very ill people. So that's why they got tested, is they had a very ill person, and they got tested that night.
So, right now, we seem to have smoothly moved into discussion of school procedures. That was well done, everybody. That's a good sign for future meetings. Is there any other procedures people have seen used that maybe we should consider using?
I will say, having been inpatient, I'm sure inpatient people, we protect the staff first. I mean, the staff is 100% protected. That's face goggles and masks and full protection. And it's so far at St. Mary's, there's only been one transmission, if they're protected, if they're willing. I mean, which is, I'm just saying, I don't think to the point that there's all these asymptomatic people coming in. My belief is that you can't stop it. I mean, that they're coming in, that you can't stop it. And I'm sorry, I'm not trying to be mean about it, just like, you can't stop it, so then you gotta protect the person who's at risk for the disease, right? I mean, as I see it, and I apologize to everybody, like, I see the older people at risk in the older teachers at risk, not necessarily the kids from the disease, which is, they get the disease, but the older people very much can get ill from the disease. And that's, so mine is protecting the teachers from the disease, maybe your only reasonable choice.
So we should definitely be doing it with our screening staff, who's ever doing that at the beginning. But then also consider that we should be providing the full, as you were saying, not only the glasses, the mask, possible face shield, possible clothing, to staff that would fall within those
And there's
categories.
people that have very close exposures, to me, like the physical therapy people, and there's, I don't know how you, we go to full shields, right? But in a regular setting, we think this works pretty, at our place, we use this as our day-to-day.
Dave, this might be a really good segue into what I think Sarah, you and Kurt have been doing. I think we have like a presentation we've been using with our staff, but it gets into exactly what you're talking about, Bill, is what's our kind of our PPE protocols and who gets what. And I know that Kurt and Sarah have worked closely with that and have been doing the training for our staff, so maybe this would be a good time to transition into that. That's directly related to.
So,
Do you want to just?
yeah. I'll just use this to scroll through a little bit and give you a brief overview. All week we've been providing training for the teachers. Jenny and I, the other school nurse, put together this presentation that we adapted from the Department of Public Instruction and the Department of Safety and Professional Services. What we stress with staff is that
Can you make it bigger?
we can't, because it's that with Google Slides, unfortunately. Sorry.
I was printing out the.
So what we talked to staff about is how COVID-19 actually transmits, and that we're really trying to control for those respiratory droplets. And so, everybody in the district needs to be wearing a cloth face covering, and doing these basic protective measures that we all do well: covering coughs and sneezes, physical distancing, hand hygiene, cleaning surfaces, and staying home when ill or exposed to COVID-19. So we went through each of these, and then we said, we talked to them about, knowing what your level of risk is. So if you're a paraeducator who has close contact with a student who's, number one, possibly not able to tolerate a face covering, right, because they have sensory issues, then we need to talk to you about your level of risk and what additional PPE we can provide. So we went through just basics here. And encouraged everyone to talk to their district level administrators or supervisors if they're in one of those types of positions that they would have a risk of additional exposure. We defined cloth face coverings for people, gave examples of what would be acceptable and not acceptable face coverings to give people good visuals of that. And just kind of gave basics to everyone. And then we talked about hand hygiene in specific times throughout the day that they should be doing that, and put in hand washing and hand sanitizer videos. It's a basic skill that we all do, and teachers are really good at doing it in a normal year, but it's more important than ever that they're doing it correctly this year. We talked to them about the facility cleaning policy and the CDC guidance for cleaning and disinfecting, talking about steps and, cleaning frequently touched surfaces and things like that in the classroom, as well as reserving those stronger chemicals for the custodial staff that's trained to use them. Staying home when they're ill or exposed to COVID-19. And I think that we've all seen these, but DHS has guidelines for returning to school after COVID-19 that has a number of different scenarios, and kind of talks about, if you've been exposed, how long you need to stay home. If somebody, has a sore throat at school and they go see Dr. Ranum and find out it was strep, then they can come back according to the normal guidelines. And things are laid out there in both the DHS guidelines and our new revised health guidelines for attendance. So we tried to be really clear to let people know when they could return after illness. And then we talked about just a basic overview, because teachers and staff aren't as familiar with PPE as we are as healthcare professionals. So we just wanted to kind of let people know what options were available to them. And we talked about what are the benefits of a surgical mask over a cloth face covering. We talked about face shields and how if you wear a face shield, you also need to have your cloth face covering underneath it because it doesn't qualify on its own. Eye protection if you're at risk of getting splashes. And then we really talked about how, we all just shouldn't put on a pair of gloves when we go into the classroom in the morning and touch everything around and touch our, that COVID doesn't get transmitted through our hands, and that hand washing is really the mainstay, unless you're going to come into contact with bodily fluids. And then just some more basics about gloves. We showed them a really good video of a nurse that has that good powder that glows under a black light, and she touches the water bottle that has germs on it and then touches everything else, and she thinks she's protected, but she's really not. So I think that that's a good visual for people to have. And then just basics of how to safely put on and remove, how not to wear your face mask. And then videos from, how to properly take off your gloves, how to wash things if you're going to wash it, and then these CDC videos of donning and doffing PPE appropriately. And the thing that I say at the end of the training is that, if you're a person who's using this PPE, it's really important that you know how to use it safely, and we don't want to give people a false sense of security when they've got this PPE on, because if they're not putting it on and taking it off appropriately and contaminating themselves in the process, then there's no point in providing it for them. And so, we want to make sure that people who are using this watch the videos and probably do some type of return demonstration to Jenny and I that shows we're not going to contaminate ourselves in the process, because teachers and paraeducators are not used to putting on and taking off PPE like individuals in the hospital healthcare setting. So that was what we ran through, and we're open to any feedback of anything else that you might like us to include.
If I can just add something, Sarah, thank you for going through that. A few of the things that we've kind of laid out as a standard, and I think this is a kind of a backdrop to what Sarah said, is the basic piece of PPE everybody has is their face mask. And then from there, it's encouraging the hygiene practices of washing your hands and any of the other items with regards to the hand sanitizing gels, etc. And then any of the additional PPE has been a thing that Kurt and Sarah and the other nurses have talked about as far as what your job is and what you need as far as additional services. So we have some of the nursing staff having the N95 masks. We also have people who are going to be working with kids who might not be able to wear a face mask to give them something and something else for the adults and the child. But a question that definitely came up in our last board meeting was with regards to face masks and what should our standard be. Because from public health perspective, it allows for the neck gaiters to serve as a face mask. And the question came up, it's allowed by public health out of the Dane County and Madison Public Health guidelines. There's definitely things that have a better level of protection, but is that adequate? If somebody is simply wearing a kind of a gaiter over their mouth and nose, or should we have a higher standard? I think that was a question Mike brought up at the last meeting that he asked for this group to think about. So I guess that's kind of a lot of information as far as how we're looking to walk through it, but basic protection, somebody in your office, somebody in your classroom, it's a face mask. And then as you have closer connection with kids or kids that could potentially be ill, you have higher levels of PPE. And then wanting some feedback on the types of masks, if there should be a different standard than what public health is putting out.
Valerie had a question. Go ahead, Valerie.
I'm going between a few things, so this may have been answered and I just muted one part and not heard it, but somebody brought up keeping our staff safe and appropriate PPE for keeping our staff safe. As a physical therapist of the district, one of the advantages is I know a lot of the job requirements throughout the district, so I know our OTs have to be within reach. I know I have to be within reach. I know our speech therapists have to be close enough that students can
So, I mean, I think, Dr. Branham, you brought up about how your staff is handling it within a clinic,
Right,
which would
we're-
probably be very similar.
Right,
And
we're-
what PPE are you using?
So we use at two different levels, and I don't know, the one is the hospital level, which is that is full gown, full gear, you know, and that's the whole PPE thing. That's at the level of the people that we know have COVID, all right? And then in the day-to-day of the people that we basically, I dress, well, I do have a cloth mask, which I left at home, of course, which is the other problem. And this is what we are. I mean, I have goggles, and I have face mask, and I wash. You know, the people who are, I believe the people who are super, my personal, and I'm open to people, is it changes every day, so it drives us, that just drives you crazy, it drives us crazy because it has changed. Because not that long ago, the others were legal, or good, and now they're bad, the gators. So it goes back and forth, but I believe, I mean, that if you can protect your eyes and protect your mouth, that you are probably relatively safe. In a person who's in a room, I don't know, and I'm open to listen to anybody else, like whether the N95 for that physical therapist makes more sense, you know, whether that's a hospital setting. I don't really know yet. I mean, and maybe the infectious disease people know how they feel about it, but I don't know what you guys are doing.
Yeah, I would just share, I mean, so when people have people in direct patient care, it's, we have surgical mask and face shield.
Yeah.
So, and it's all shields, we're not doing goggles at this point. And so I think that in those cases where you're having more prolonged, more exposure and direct contact, the shield makes a lot of sense because the shield also protects your mask. And that's with asymptomatic patients. When you start getting a symptomatic kid, then it's different PPE, you know, for that. So then we're going to, you know, we still, for a symptomatic patient, would have face shield, mask, and then you'd talk about gown and gloves at that point. We don't require an N95 for symptomatic patients for just routine
For symptomatic
interaction.
you do, or asymptomatic?
We do not require an N95 for a patient with a cough because we have our shield and our mask, for example.
So I think you really have three levels. So you have in the classroom, we're physically distanced, everyone's masked. The mask is totally fine in that environment. In situations where you're going to have staff in close contact with a kid who's either not masked or physical therapy type or stuff like that, then I think you need mask and probably preferably face shield just because not only does it protect mucous membranes, but it keeps your mask from getting contaminated, and that's good. And then let's say you have a kid who shows up who now has symptoms, who you now are basically calling a PUI, person under investigation. Now you're going to use mask, face shield, gown, and gloves, and then get that kid out of the school to where they need to go. And I think that's how you kind of sell it, or not sell it, that's how you explain it to your staff. It's all based on the risk that staff member is exposing themselves to. And that's why you use the different levels of PPE, because if you're really close, those large droplets could get in your eye. Face shield becomes important. If you're 6 feet away and everyone's masked, you're not going to get a large droplet in your eye.
Right.
You don't have to deal with the inconvenience of having a face shield on the end of the day. As far as masks go, I think it's going to be really hard to say a gaiter isn't okay, but some other thing is okay. I think there's two things you could potentially ask or add. I think you'd want to say that whatever you're wearing for your mask needs to be at least 2-ply. And then I think you need to say that you can't see through it. So it has to be completely opaque. If you add those two things, I don't care so much what it's made out of. I know it's thick enough and it has enough layers where it's going to be pretty effective. What you don't want to do is have someone come in with some sort of see-through thing and say this is my mask. Like that's not going to work.
Can we clarify though, like the masks that are designed for like the speech therapists that have that window that we have?
Yeah.
So that's not what we're talking about for the public that's listening. Those would be acceptable.
Yes,
but
absolutely.
not some thin nylon something.
Right.
The other thing with that then is when you do have a symptomatic patient, and you have a face shield on, just making sure you have PPE cleaning practices and policies in place to be able to disinfect, because that now is contaminated. If you have somebody who's coughing and you have potential aerosolization in that enclosed space, you just want to make sure that you're cleaning that and have good protocols. People are informed about that.
Are you treating the gloves and stuff as biohazard? Okay, so when teachers throw them into trashes, that's okay? All right.
Only if they're visibly soiled with blood or body fluids, right? Then they would be considered, they need to go into a hazardous.
Right, I was just wondering with this situation.
Yeah, the point that you're making is where they're wearing the mask. I mean, for people who are not familiar with masks, it catches me up sometimes, the places they can put that mask. You know what I mean? It's like it's not on their nose, it's not on their face.
Right.
They have the mask, but.
And we really stress that people, like even tonight in this, I haven't worn this mask, but, and as I'm talking, it's falling down. So we're really trying to stress with teachers, like, get something that fits you well, find out what you can wear all day without touching it all day long, because you're contaminating yourself when you're, constantly readjusting your mask. And so we're trying to make our education for them practical, right?
Which just goes back to the face shields. People have to know how to manage those. And I watch too many people with the face shields and they're wiggling around or flipping them up and then they've got their hands over their eyes and it just drives me nuts.
Yeah.
So, they go, hey, you're actually, you put your finger on, it gets there and you put it in your eye, you're staying, and it's the same. So I don't think we've got a perfect thing. I love it at the shields and the goggles and the more layers, but it's hard.
But if you go back to what Jeff said, if we had a standard of a 2-ply, you can't see through it, does that seem reasonable?
Yeah.
I think you need to, and the no exhalation valve piece that's in
Yeah.
the standard. So.
Getting back to the point.
Yeah, I think you guys had that. I mean, the presentation
Yeah.
was good. You had a lot of those details in there.
Yeah.
I gotta say, you guys are making me feel so much better that all my hours of biological chemical warfare training in the military is finally coming in handy because I know how to take this stuff.
This is where it's at.
So are we doing a similar, not similar, a smaller scale education for students the first couple days on how to wear a mask and what our expectations are in school?
So what I did was provide the K through 4 schools, so they're working together on their planning. And there's a hand washing curriculum, like an age-specific hand washing curriculum, and like YouTube videos and things like that for wearing masks. And we've said in our committee planning meetings that the first 2 weeks of school are really going to be about teaching kids social distancing, how to wash your hands, how to keep your masks on. And so I do feel like that's on the agenda for the building principals.
One of the other things I think to think about with PPE is just what we call PPE fatigue,
Yeah.
As well. So there were a couple issues of, one is just skin breakdown or things where somebody's mask isn't fitting well, and so making sure that you kind of have things, especially for the teachers and the kids, is what can they do to be limiting that, because as soon as it starts hurting or rubbing, they're going to want to take it off. And the second thing was just really advising the teachers especially. So what we find is people, when they're in direct patient care, they're really pretty good about their PPE and doing that, but because they're getting tired of it, they need to have places to go and take breaks. And if they go and take breaks, they tend to congregate together, and there's this assumption that, oh, my coworker and I are safe, and so there's a tendency to let your guard down. And that's where you're probably more at risk from your coworker in that way than you are from maybe one of the kids where you're maybe more on your guard. Just reinforcing that still distancing aspect and needs to be there, because people naturally just get tired of wearing it.
And then our other PPE, as Jeff, you had said, and I think a few others, that as we have closer contact with kids, then we have different levels of PPE, which I think is congruent with what Sarah and you and Kurt, is that right?
Absolutely. We have enough face shields for every staff member to have one. I have 1,200 actually. We have about 550 employees or something like that, I think. So every staff member can have a face shield. We've ordered gloves. We've ordered a couple of styles of glasses and goggles for people because comfort and all of that. I mean, we have gowns, we have gloves, we have, the only thing that I don't think we've ordered are the little the shoe covers, which we feel we didn't need to do, but otherwise we have everything. We have some Badger Shield Plus that arrived that we're going to be using for our speech and language pathologists, our staff who work with students who have a hearing impairment. So, we've got a great variety of items for staff, and then as we know exactly which students are coming in and what staff are going to be working with them, I am handing those things out as staff make the request that, hey, I need this because I'm working with the student. and all of that. So we.
So it's congruent really with what Val was saying, is as she's working
Yeah.
closer, we're providing more of that PPE.
Yeah, and our nurses, just so you know what we're doing with our school nurses and our health office assistants, we were able to get a supply of N95 masks through the county EMS program, and we put in a request for some more. We are working with someone at SSM Health in occupational services to get them fit tested. I already have signed the agreement with Battelle, the decontamination service over by Truax, to decontaminate those for us. And we are working on, and we'll be taking to the school board at the next school board meeting, you have to have a program, right? The
Respiratory,
Thank you.
respiratory, yeah.
Program that, so we have a template for that, and we are finishing that so that it can be approved, because we have to have that approved by the board in order for us to participate in that, having that N95. So we are doing all of those things. So our health office staff will have N95s available to them. We have one other staff member, kind of to getting to your point, Dr. Raymond, we have one other staff member who reached out to Brian and I, indicating that because of a condition that that individual has, if she has an N95, she would be able to work with students. If she doesn't, she can't. So she is going to be fit tested as well with an N95. So that's kind of the lineup that we have.
So are they required by their position to wear these? Or are they only going to say what they're comfortable with wearing?
The N95 piece or
Any of
anything?
them? Any of them? Is it up to the teacher, or are we saying your occupational therapy, you have to wear this? Or you have to wear this? Or is it just saying they want to come in and say, I'm good with this, and I'm working 3 feet from somebody?
Right now, what we're doing is we're providing them with the equipment.
What they feel comfortable with.
Yeah, so just to be clear, you can't let people choose what they want to wear. So if there's a high risk there and someone does not want to wear their face shield, that's not an okay thing. We have to figure out how to mitigate that. Otherwise, you're going to have a transmission through some of those people who have decided that they want to do something that's less than what the science would suggest is good.
I agree. You probably want to look at the jobs that you know are going to require that type of interaction and say that that's the standard PPE for those individuals to be wearing. And then there may be other instances where people may need to wear more PPE, but it's not necessarily every first grade teacher isn't going to need to, but your PTs, are.
PT, OT, speech, and those the paras probably have some.
The nurse, who's doing evaluation on kids in the.
Yeah, that's a really good point, and I know that there are staff with differing levels of comfort, and even over, camp kindergarten, that we had PPE available, but not everyone chose to wear it, and it is a good point that, the chain of transmission is with all of us, and in order to keep the whole school community safe, people who are in those positions.
Val, does that answer your question?
Valerie?
Yes.
Did that answer your question pretty well?
I'm in between. There's a lag between the two things.
Yeah.
So I missed the last part of what everybody was saying.
It was about that basically we should have minimum standards by job classification to say that OT, PT, paras should have to probably wear face shields.
While they're doing it.
While they're doing it.
In the hallway, that's probably a different case.
Yeah, right.
In the actual space, there is probably reasonable.
So it's not just, it seems like we're looking at 3 different levels of PPE based on what you're saying. And that it should be mandatory based on what your actual job is happening at that moment. You have to be in that level
You
at
kind
a
of have your
minimum.
general classroom teacher, you have the teacher who's working in close contact, like Val said, in a PT setting, and then you have our health service staff who are working in the health service level, those kind of being the 3 levels.
And you just make sure then that you know that, so let's say a physical therapist or a para who's working in close contact with a kid, that's when they have the face shield on. They don't need to wear that face shield when they go walk to a different room, just make sure people know that there's some leeway with that. It's not like you're.
Yeah, that's how you should, the transportation.
So then you have another level though where it's with a symptomatic child, right? You're in that interaction, because that's a separate, it's sort of like no matter what your base PPE level is, if you're in direct contact with a symptomatic child, you then go into the symptomatic PPE.
Or you call
Right.
it PUI, I believe?
So
Person.
what we call a PUI, person under investigation, is the public health term for, we don't know that this person is positive, but they're exhibiting symptoms or something else that makes us suspicious that they might be, and now we're testing them to see if they actually have the disease. That person is pretty high risk, because now you think that they might have it. Now you take additional precautions.
So you treat them as if they were symptomatic,
You
right?
treat them as if they have the disease.
If they have the disease, yeah.
So those would be the same
Always
level.
best to be above.
Yeah. The people who fail the screening, whoever's evaluating them in whatever room or setup you have is going to require that's the gown, gloves, shield, mask. Then you have the people who are like the PT who's going to be in the shield, mask, and then you have the people who are the routine teaching environment who are going to be just a face covering.
Yes, and that was our plan. The staff were gonna be in what we're calling our isolation room. We'll have the full gamut while they're there, because those are the students that we've screened one way or another.
Yeah.
And have decided they need to go there as opposed to our regular health office for the scraped knees and those kind of things. So anybody in that isolation room has the full gamut of people.
Well, kids who become symptomatic during the day, they're in class, teacher says you don't look so good, will they go to the health office or they would go to the isolation room?
The isolation room.
Okay.
So, and even worse, because this happens to us even, actually, it's like where one of our staff has been exposed directly or something. Do you have like a COVID code where you have to that kid is now positive and they're in the class? Or you guys have a strategy for removing them without?
Yeah, so we've talked about the teachers have, our health office assistants have walkie-talkies, or a lot of the teachers even have their cell phones that they can send a text. And instead of having that student, traipse through everywhere, if the health office assistant can go and get the student and take them to the isolation room, we'll have them do that. The other piece is like making sure that kid has a surgical mask on before they move around. And we've moved our isolation areas completely out of the main offices so that those kids won't come into contact with like our attendance secretaries and the principals, people who live in the main building, just to try to keep that
To the
separate.
gym? You're just taking the gym?
Every school has a different space available, but yeah, I think that's and making sure that they do come out right away and that we're aware that. The other thing that we've done, and it was recommended by DPI, is to really try to cut down on our healthy health office traffic. So, the minor first aid and bumps and scrapes and things like that, we're providing the classroom teachers with the supplies that they need to handle that, so that we're not mixing cohorts in the health office, that we'll be taking care of those things inside the classroom. And if it's something big that a teacher can't handle, obviously we're available and we'll take care of that in a healthy space. But they've got protocols for, how to deal with a nosebleed, the teacher does, and supplies within the classroom. So hopefully that kid won't have a fever. If it's a little bump, they can get an ice pack in the classroom instead of getting everybody together in the health office like we normally have.
And you have space for multiples?
Yeah, so the rooms that we have probably can fit 3, 6 feet apart. We talked about whether we want to have, I don't know that we can have separate rooms for the symptomatic kids. I don't think that we've got enough space for that, but if that's something that we need to acquire
I think it's
space.
a discussion, if you know somebody's positive.
Or they're exhibiting symptoms, yeah.
Or they're exhibiting symptoms, like how are you going, that's where the whole, and we know some that don't have symptoms all the time, and now you know somebody is, that's to do where the liability problem comes in, like now you know, right?
Yeah.
Before you didn't know, now you know. Is that somebody you want to be with somebody, within 6 feet of somebody?
Somebody else, right.
But if we think they have COVID, we really don't know, they would go off-site to be tested, right?
No, not
Or
necessarily.
can we test them in school?
No. So if someone is symptomatic and they come to us at school, what we'll do is put them in our isolation area that is only for students who have symptoms of COVID, which unfortunately are symptoms of, you know, a sore throat, abdominal pain, nausea and vomiting, like all of the things that kids get. You know, anybody who gets sick and comes to the health office could be COVID, right? So what we can do is try to separate, you know, spread them out as much as possible, make sure that they have their mask, make sure that staff has their PPE. But no, we're not set up to test at school. And really, we can make a recommendation that they see their healthcare provider, but DPI advises against requiring people to go get tested. So that's, you know, a discussion that we can have as well.
The key piece to it is making sure that parents have updated current contact information in our system so that we can immediately call them, so that they can also immediately make arrangements to come and pick up their child, so that we're not having a backlog of children in our buildings when we've identified them as having these symptoms, because we have to have parents be able to respond quickly. It doesn't have to be the parent themselves. It can be we allow for emergency contacts to be listed in our system. So anybody that has the parent's permission to pick up their child can come and pick up their child, but we need them to respond quickly so we can get the student out of our building as quickly as we can.
That's actually one of my concerns. And I just think, because mine is like, hey, if you have a straight, and I apologize for talking about a straight nuclear family and the dad and mom are under 40 and the kids are there, there's a little risk. The day I send the child home with the 70-year-old grandma, now I have acquired risk. You know what I mean?
Yeah.
And I can't protect her. You know what I mean? And I don't know how to, like, is it, that's what I'm talking to the people at the clinic, and I was like, hey, this is different. This is very discriminatory event, this infection. And do we discriminate against you taking care of your grandkids at this time? Because that's almost always who the contacts are. I don't have a solution. I'm just, that's when I talk to parents, I'm like, hey, the kids I'm not so worried about actually, and I don't mean it that way, but I mean, I am really worried about secondary contacts because all the people that I have had to take care of have gotten it from their grandkids. You know what I mean? And that's, or kids, except for the last one, which got it from work. But I'm just trying to think of I don't know how the scenario is going to go when you say, come pick up Junior, and grandma comes, and now that's, and the second one is like, what do you do at our place of work? We get calls like where somebody says, my sister's positive, and I saw her yesterday, or saw her 3 days ago. You know, what do I do with that teacher that day, or that worker that day? So it's difficult, so I'm whining a bit about it.
I think where it gets really complicated really quickly is, and I may have heard you wrong, but you know, this idea that I'm a child, I have acute upper respiratory symptoms, and I think I heard you say that DPI has said, you know, they don't have to be tested, you know, they even potentially could come back to school.
No, they couldn't. They can't come back to school. So it's very
until the symptoms are controlled.
Yeah, until
Okay.
they've been, you know, seen and diagnosed with something else. They've been, well, if they're tested, like their symptoms have to improve. I think it's a minimum of 10 days home if you've got.
Okay, so for the acute, okay.
For the acute
just
symptoms.
they're saying they don't require the test necessarily,
Right.
but they would have to. Then they'd have to have the 10 days. Yeah, right.
But I think the question is, like, are you going to screen everybody who comes into your health office who has symptoms? And the answer is no. And can we force parents to go and get their kids tested before they come back to school? No. But there are guidelines for when those children who are sick can come back to school.
So if a kid, sorry, just bear with me here, but child comes and is symptomatic and they go home, and then you don't know what happens to them, you know, I mean, will the public health department notify? They won't notify you, so you're dependent upon the parent to notify you that if the child is tested and positive or not.
Parents
So
would notify and public health would notify.
So public health will notify you during the contact tracing component. So I think there's that piece of if they're not tested, you know, when can they come back? Does that kid who doesn't get tested, who goes out, is that an automatic 10 days, or is that just until your symptoms are improved and then you can come back?
Yeah, and we have written guidelines for it, and it's gonna be, I mean, case by case, and we've already said, we need to like set up the COVID command center and be like, okay.
You literally do.
Yeah, Johnny got sent home today. these were his symptoms, and I think it's going to take, like Jenny and I, as the nurses, communicating even with primary care providers, if it's unclear, whether that child should be back in school.
I do want to just make it clear that public health will only contact us if, through their contact tracing, they believe that the child was in that contagious period on site. If they determine that the student wasn't here when they were in that contagious, is it two days prior and 10 days after or something, they will not contact us. So we won't always know, but they will contact us if they feel that the student was contagious when they were in one of our buildings.
And that may be something that we bring to this committee too, for like approval of our protocols for, you know, we've got the guidelines, and DPI is supposed to be coming out with sort of like cheat sheet for school nurses, you know. But I think if you want, as we continue to develop those things, we'll have to just maybe bring it to this committee.
And I think part of what we have right now, Kurt, you were part of working with public health. We have like 16, 17, 18 different scenarios as far as what this means and what protocols we follow. I think the concern that's kind of come up is exactly as Sarah said. We have a child who comes forth and they have symptoms. They're sent home. If they don't get tested to clear what that is, they don't go see someone to clear what's happening, they're out for that 10 to 14 days. And then that was a piece that Dr. Waldy and I talked about at one point, was we could be kind of quarantining kids that don't need to be quarantined for that long and keeping them out of school. So it's how do you deal with that?
Is why it's, so I know DHS is missing, you can't require a test, but like if I'm a parent, I got a kid in the district, I want to know what I need to do to get my kid back.
Right.
And the answer to that is you got to get a test, like as fast as you can, so your kid can get back in.
Right.
So that's a message we give to our families. It's not required. We wouldn't make you. But the alternative is your kid's out for 10 days, or they wait a couple days to get the test, and they're back in at day 4 or 5. It's a huge difference for those kids.
And it's strongly encouraged, and you know, I think the communication from the district has to be, we've got the Alliant Testing Center that is running, you know, from what we hear on the public health calls and experiences, like it's pretty efficient, pretty easy. We got tested before we went to visit my in-laws, and my kid sat on my lap in the car because she had a sniffly nose, and the kid sat on my lap in the car, and it was a simple, easy peasy, they didn't even cry. And I think if we can get that message out to families that, you know, it's not the most fun test in the world, but if it helps you, you know, it helps us, gives us more information, then we should all be making an attempt to do it.
And the other thing, for families who have a primary care provider, you're going to find that contacting that primary care provider and getting tested through the health systems is going to be even a more efficient way to get those tests. So that would be a good option too. It's not like everyone has to go to a line if you're fundraising with a health organization.
That's what I was going to ask you. Do we suspect things are going to change to be more with flu season coming on, that you're going to want to know and there's going to be more testing? Because I've had family members go in and say, you know, you're not in that age or you're not here. And this was 6 weeks, 8 weeks ago. Has things changed? Are we going to be prepared to be able to go to our health care provider or send students to the health to get it?
The system can now do 1,000 a day, right, which is enormous. We went from, I think, 50 to 60. UW is a much higher number they could do, but the testing rate, there's nobody I've had sent in that hasn't got the result the next day in our system right now.
Okay, so
I mean, we're not restricting for symptomatic patients, you know, and so I think that's the message. People who don't have any symptoms generally need to go to Alliant because the health systems don't have the capacity to do all of the asymptomatic testing.
That's true.
The thing just to be aware of is that, like I think is public knowledge, you know, there's the possibility that, you know, testing could change based upon reagent availability and some of the other supply chain issues that it's just a national problem. You know, we don't have that problem right now. It's something that we monitor. So things could change, but right now, I think Jeff's absolutely right. You know, at least at UW, and I believe at Unity Point and SSM, if you get a symptomatic patient calling primary care, you can get a test.
You know, it was kind of interesting, before we came in here on Wisconsin Public Radio, they talked about the flu season down in the southern hemisphere, and actually it was less.
Yeah,
Less
right.
contacts.
Less.
Right.
People are wearing
Yeah,
masks.
yeah, less flu.
And so forth.
Yep.
So we talked about that, you know, having double whammy, but, you know, that's not what they're experiencing in the southern hemisphere.
Yeah. And Sarah, how many kids do we usually see on a typical day just for illnesses in one office? And what is going to happen when every sniffle, every cough, every allergy symptom then comes through your door? Much like they're going to probably see.
And one of the things that we've talked about is teachers really having a heightened awareness. So, you know, what is a cough? Like if you swallow your spit wrong, you might cough once, right? You know, what's a cough? Like that kid does not need to come for isolation. And so I think it will take some education too. I mean, we'll take symptoms seriously, but also, you know, I think we put in our health guidelines that, you know, if it's let's say it's a kid who doesn't have a fever and they sit in the health office for like, we want to give like a less than 15-minute assessment period, right? That's like the definition of a close contact. And if within 15 minutes we've identified that child just like swallowed funny and there's no bad coughing going on, then we can send that child back to the classroom. And if the child then gets sent back again with a cough, then yes, they need to go home. So kind of building in a system for, you know, we know that a kid might cough once or a kid might sniffle once, but we're not going to send all of those kids home. And hopefully what we've done to get rid of, you know, most of the kids that come to our office are, you know, there's 6 kids in there after recess because they all bumped their heads or something. Like, that's not going to happen. And moving some of the lost teeth and the other stuff that we do, hopefully. And then we're also really trying to be aware of the fact that we've only got less than, you know, there's a whole bunch of people who are electing to go virtual. And then we've got half of what's left in the morning and half of what's left in the afternoon, grades K to 2 right now. And so that's a drastically reduced number of children in the building anyway, at least for right now. So then hopefully we can hone our processes with this reduced number of students. And then the conversation is it realistic based on what we're seeing with this small cohort of students to do more, right? Or what do we need to do in the health office to accommodate more students?
And I'm assuming that somebody's in your office 20 minutes before the bus leaves, and you think that they need to be taken home. The parent can't say, just send them on the bus. You're going to call them and say, no, sorry, you're going to have to come pick them up.
And even in normal school, you know, we don't do that. Yeah.
So is there going to be recess?
Right now, there's no recess. There are movement breaks throughout the day, but no recess because it's hard to ensure physical distancing.
Okay, I didn't hear that.
So basically, they're running like 2 hours and 40 minutes morning, afternoon.
Oh,
But
so-
it gets rid of the lunch break, it gets rid of the recess piece. But we have to get them at least moving in some respect. That's a long time to sit, particularly for a kiddo. Those are some of the things that we're trying to work through how to do that.
Well, we've spent a lot of time on the policies and procedures so far. Aaron, we're just getting you hooked back up again. And so, should we move on to the concept of possible metrics for our internal opening and closing of our schools? And as we know, we have Dane County's numbers, which is, 42, 39. Oh no, we're currently at 42. 54, 39,
19.
and 19. Which obviously we have.
Which year are we trying to do?
Aaron?
Yeah, I've been here the whole time.
Oh, okay. All right, I was just getting you hooked back up again here.
Oh, I've been here.
Oh.
For the last 48 minutes.
Okay.
Phone's on me so that you don't hear me coughing, but.
Uh-oh. We were just talking about coughing. Oh, no. So our first screening patient will be Aaron, and then we'll practice on him. So as we look at it, our current process right now, I believe, is if we have a student or a faculty member or staff who came up positive, we would basically quarantine their class at a base quick level. So what, though, would cause us to consider literally shutting down a school? At what point would we get to that level? Or does that level occur?
Well, let me add a little context to that. So right now, closing down a school or a school district or a building falls with really two entities. Public health has the ability to do it, and we as a school district, administration and board have the ability to do it. So it's kind of similar to like a snow day. If it's a bad weather day, it's not safe, I can close down school for the day. Same type of thing with this type of an issue. Public health has always had the ability to close down a school or allow access. What that criteria will be is not necessarily completely clear. The guidelines here are really for what it's going to take to open pieces up, and I think that's what I provided in your packet to you. I think kind of the question that I think that kind of fits in here is when we have if we had a child become ill with COVID in a classroom, then we obviously have protocols that I know Kurt has worked with public health on, and Sarah and the others have, where we may have to quarantine that class for a number of days. There's also the piece if the teacher comes down with it and looking at kind of the contact of where that teacher was, that could quarantine the class and the teacher as well. But it kind of gets to what level does it require before public health actually would close us down? Do we have to have some sort of an internal kind of metric? If a classroom is closed down, is that a trigger to do it? Is that too early? Is that something where we have to wait for multiple? It's kind of that in-between piece. The message I at least get, and Kurt and Sarah, you can jump in because I know you're on some of those calls too, a single classroom being quarantined is probably not going to close a school. And but what should it be up until the point where public health does, which is kind of an undefined number at the moment.
What is one teacher as a percent of the population of teachers? Is it you have one teacher out of one would be 3% of the population?
If you look at like our K2 schools, we have anywhere between 4 and 6 teachers per class, per grade level in a school. So K2, if you look at just Prairie, Brian, you probably know these off the top of your head looking at it right now.
We have right now 344 teachers.
Right.
So in the district.
District level.
Every building's going to differ because of the size. Your biggest building is obviously the high school. You're about 90 teachers to your smallest building. You're 20.
The K3s?
Teachers, just straight up teachers.
Yeah,
the K3s that'll be there is like 12. I mean,
so your again, smallest building is probably again, just straight up classroom teachers 12. Your biggest would be 18.
And then we'll have teachers in their other rooms who are teaching some of the virtual pieces, so they'll be on
so,
site.
But I'm just saying, classroom teachers, it gets more complicated when you start talking about OTs, PTs, counselors.
So that's how I would perceive it, as sort of the percent of your adult population, I think. I mean, that's how I would perceive it. You might be one teacher, but if you have 2 pairs in different classes that are, you've got a problem.
I like the percentage idea. I think there's probably also a percentage of students, because at some point, if that many students are having to learn virtually, potentially when does that, come
becomes
around?
unfair. I mean, I'm sure you've heard plenty of that be unfair, right? I mean, I apologize for bringing it up, but I think some sort of percentage, whether it's 10 or 15%, I don't know what the gap is there. But
I think the old models that look at that would be like the Harvard Public Health model looks at, and it's more for communities, so it's cases per 100,000. You could probably do the math and figure out cases per your total student body. You might want to even figure it out per location, so that Arboretum isn't closed because there's something going on at Prairie.
right, that's what I believe.
So you could look at it that way. I think, in my mind, I think public health is going to have the problem that closes you before you do. So one of the issues that would close you is when you have a positive case, public health has to do contact tracing. And if it's just one classroom, that's not so bad. Maybe it takes them a day or two. There's a decontamination cleaning thing that's on the school, but that's not going to take that long. But then, like, let's say you're in this situation where you've got like 9 through 12 running, and you don't have one teacher or 12 kids. You've got things moving around a little bit more just because that's what you have to do for those higher levels. You know, one kid might then have exposed 4 different cohorts. Well, now public health has 43 people to follow up with.
right.
They're not going to get that done in 2 days. Now you're probably looking at a more extended. So when I broke it up in my mind, I thought there was basically 3 groups. So there's like the one classroom, kind of like your K through 4. There's 12 kids in the room. Public health probably a little bit conservative. You might need to quarantine the whole class if one is positive. From my perspective, if you know that all the other kids were masked and all those other kids were 6 feet apart, and that there was no close contact, I'm not even sure you need to completely shut down that classroom. But that could be debated. And then I think if there's this, intermediate, middle, high school where it gets a little bit trickier because you just can't have 12 kids in a room with one teacher and do high school. If you have a positive in there, your cleaning gets to be harder because you're going all over the place. But I think the thing that's going to shut you down is public health is going to call and say, we don't have this figured out yet. We got to keep this closed until we figure out, who's all there. And that would get you. And the third one would be nothing to do with the schools. It'd be what's happening right now. We're seeing really high levels in the community. We want it to be less than X per 100,000. And until we see that number, we don't think you should be doing. And then, this whole cascade that they have, that'd be the third thing. If numbers went back up in the community, reasons that could happen, campus has an outbreak and also Dane County has much higher cases. Mask mandate is pulled back. We didn't really see case numbers so high that we couldn't have schools open. I could see public health just shutting it down. Those would be longer term shutdowns, 4 or 6 weeks. But I think you have those 3 things. Very short shutdowns for like your elementary classrooms, a little bit longer for those middle to high school. And then if the community is the problem, not the schools, those would be longer shutdowns to try to prevent transmission.
So you're really thinking that basically us having a level of literally shutting down a whole building for our district, Dane County Public Health is probably going to do it faster than we would anyway.
Yeah, the only thing I can think that we would shut it down is, let's say you have a case in the high school and you know that you just took out 30% of your teachers. Maybe you can't run the high school with 30% of your teachers out. Like, how are you going to get all those people in? But I think it would be more of a staffing thing, more so than a disease thing.
I tend to agree. I think the only thing I would say to that is, in a scenario where there are more schools open and public health, what is their turnaround going to be on some of the contact tracing? And so it may be something where the board wants to think, a district wants to think about, okay, if we know that at Prairie we have positive cases this week in 3 different classrooms, or, somebody gets the call and says, this and this and this, and you might not know exactly what public health is going to do at that point, and you don't want to necessarily be reactionary, but you also want to be looking at it and saying, okay, what is that threshold? And I don't think it's necessarily a really low bar, because, but is there something, either because of the percentage of staff that are going to be out, or you just say, gee, we can't, there are 16 classrooms in a building, and we have positives in 4 over the last 2 days. There's something going on, rather than, if we haven't been acted on by public health, we may want to consider. And I always hate to get to like really explicit metrics where it's like, if this, then this, but it's sort of like, this is the guide when it's going to trigger the discussion, and then we're going to sit down and, have a phone call, what should it be at that point?
So that's a good point, because not to disparage public health, but let's just say they get far enough behind where they can't even let you know that they're not caught up. You'd have to have something that you own that says, we're not ready to go, so that might be
So do
something.
you think percent of classrooms then, would give them some guidance? I see it as what you're saying is, it's going to be perceived, right? If half the classrooms have the disease, you waited too long, right? If a third of them have it, it might be too long. If 25%, that's probably a reasonable thing to say, we're not in charge anymore, right?
I think there's a trigger, right? So it's a percentage of, and this would be something you guys would determine operationally, this percentage of our teachers are out, like operationally we just can't do it. Like, that to me is, pretty straightforward. On the student side of things, I think there's a trigger that says this warrants a conversation, whether that's this, subcommittee, ad hoc committee, or that's something else that, this is a situation at Arboretum, we have this many students in this many classes who are positive. it then triggers a conversation about, do we need to shut Arboretum down, as opposed to saying, when we reach this level, because there may be a perfectly good explanation, that may, you don't want to unnecessarily shut it down either.
But living in the community, as I go, hey, and I'm sure you, it's like, that means, that circle doesn't just go around that classroom.
Right.
That circle goes pretty big. I mean, so if you say, hey, we waited till a certain number, this many were infected, and we knew it, and then we didn't act till it was,
Right.
till we were this late, well, you just infected every bus driver, I'm just being complaining a little bit, but, how do we, how
I think-
big a circle? Because the circle isn't just that kid, I wish it was, but that circle goes.
One question that I have is for our childcare that we're providing within the building, are we keeping the students within their cohorts for that childcare, or is that
Yeah.
changing
Yeah. Those cohorts don't mix.
at all?
No. That's good.
Another thing to consider is the sibling of the child who's going to school. If one sibling is positive and the other sibling, how would we?
Yeah, that's our work scenario always.
Yeah.
Yeah, and one of our scenarios specifically addresses that, and that is a resource from, I think it's from either DHS or DPI, I think it's DHS, where it's for our staff too. If you live with someone, if you're living with someone who tests positive, then there's kind of a couple of steps. One is, are you able to completely isolate yourself from that person, or are you not able? And then depending on how you respond to that question, then you have another layer that comes. But if we do have, how we're going to treat anyone living with someone is we're treating that person as a close contact. And then, of course, they won't be able to come to school for 10 days at least, or 14 days. So they're out. Yeah. Unless, of course, they do some of the other.
How would the other families be notified of?
Yep, we have an individual in district who's working on some communications, and public health is also providing us with some templates too for notifications to staff as well as parents, families. Yes.
So to be clear, Randy, based on the way things are set up right now, if you saw a 30% number of classrooms at Arboretum that had to be quarantined, you right now have the authority to shut the school down.
Sure.
We wouldn't have to worry or delay or anything.
No, I mean, it could be it could be a piece even if we find out in a Tuesday morning that we don't have staff. I can shut it down. Yeah.
Okay.
Yeah, I have the ability to close a school is with public health or the district, and I have the authority as the superintendent to make that decision.
And how long can you do it for? Is there any time limit on that? I mean,
No.
basically, you're looking at least
No.
2 weeks,
No.
practically, if you were gonna do something like that. It's
There's
hard to
probably
say
not a
that you
time
would do
limit,
it less
but
than that.
I don't know. I mean, it depends, I think. I think that if you had, the question would be what additional positives come in at some point. You could, out of an abundance of precaution, do that and then identify that, it hadn't occurred. And I would hesitate to say that it has to be a full 14 days at that point, because it just would depend on the situation.
In
Well,
my
that probably
mind,
the
Dave, I
biggest-
wouldn't make a decision on any given day to say we're closed for 2 weeks. I'd close it for a day or two to assess it and then make a decision.
Yeah, you have to do that, I think. That's what I believe will happen to you, is you'll just have to hold it until you know.
You'll have to kind of put a hold on for a couple days and then assess where we're at and then make a decision.
I do think it's a building by building decision largely, unless it gets to the point that Jeff's talking about where the community spread and you're just seeing it pop up at too many buildings where you just say, we're going to shut down Prairie and Heritage and the middle school. Well, at that point, if it's that bad, does it make sense to leave the high school and Arboretum, or the intermediate open? It may not at that point.
But they're not open anyway, really, except for
Well, yeah, if you think about the future state, I mean, in the state right now, it's, like you said, it's a lot easier to hopefully get some of the processes down and see what happens with a much smaller volume of people.
Well, what are you seeing in terms of if families have one member that's positive, what are you guys seeing? Somebody else in the house is going to get it? Even if they isolate them?
They
in
don't
a room?
necessarily get it, but you can't say they won't get it.
Right, so I mean, the conversion rate of positive family members is not as high as you would think. It's certainly a risk. It's much higher risk than if you're not living with someone with COVID. But what we find is once you know someone in your household that's got COVID, like really seriously, especially in a family unit where like mom and dad don't want to give it to their kids. Yeah, it's not a certain thing that those other people in that household are going to be positive, but it's higher risk than if they didn't have it.
But they're going to be out for a long time
They're
because
gonna be
they have
out.
to be able to isolate from each other, and if they can't, then they have to wait until they're done, and then the 14 days beyond that. And even if, from that first point, mom gets, COVID, kid's going to be, out of school, out of in-person school for, 10, 14
It's
days.
the entirety of mom's illness, so that's probably 10 to 14 days, and then their clock starts for another 10 or 14 days to make sure they don't get symptoms. So you could have a kid out for close to
24 days.
if they have no ability to isolate from that parent.
Yep.
Or that parent doesn't.
Well, that's why I'm wondering, we're putting in new HVAC systems and stuff like that, but you have a regular house system, even if you put somebody in a room and you bring them a tray of food and sit at the door and run away. I mean, I don't see where.
That's what it basically is.
I think our vice president was our perfect example. He
Yeah.
lived in the basement for 2 weeks and no one else in the family got it. So it's going to be obviously case by case, but it is possible to isolate a family member.
I mean, this is kind of a crystal ball question, but I mean, the metrics that we have from public health, the K2 is at the 54 cases on that metric. We've obviously met that, so they're allowing us to open up. 3.5 is 39, and then the other levels is at 19. And to me, 19 seems a long ways off.
Especially with UW opening.
Yeah, that seems like a really long ways off. And
It's going to be hard to get to 19. Yeah, they said they're planning to do 8,000 tests a week. It's going to be really hard to get to 19.
Seems difficult. I mean, something would have to get.
How realistic is-
Post-vaccine, it might happen, right?
Yeah.
I mean, that was our initial thought, was it's probably 2021 before we see anything in 19.
I would agree.
Let's just restart on March 12th.
Oh boy, here we go again.
How realistic is 39 in the near future?
That's where you just see vaccine distribution.
Could be. I think a lot of it's going to depend what happens on campus.
So I think we'll get a
The community
bit
number you've
more
been seeing is kind of inching down. It's pretty close. If campus opens and there's going to be a higher volume, that way, that's going to skew that number. If campus closes and they go all virtual at some point because of that, then you're probably getting back into a more achievable level at that point. I think it's all about campus.
And campus is also, my kids in there, they're not doing, the big classes are not occurring. The lecture classes are not occurring. The labs are occurring.
Yeah, but with campus, it doesn't worry me what the kids are doing when
Right.
they're at school.
Oh, no. I know. But we told him he stays down there. You stay there.
So we should all watch the camera video feed of the college club.
Yeah.
That'll decide for us what's about to happen.
State Street, just State
It
Street.
sounds funny, but.
I have one more question about cohorts. I know in the beginning, we talked about our busing situation and how we had shuttle buses. And in the beginning of our conversation, we weren't able to not have those shuttle buses where there were different kids from different schools. And I just thought of that again when you said it's a school-by-school decision. But I'm not sure if our transportation plan with our reduced number of students has been able to eliminate the shuttle busing component and reduce the mixing of students from the different elementary schools.
And I know that there's a shuttle system, but I don't know if I've had enough information to know if that's a different type of shuttle system that's not hitting them. I almost think it's like a shuttle from Arboretum
Heritage, because that's where the child care is.
You're gonna
And
get
so-
that piece, and then there'll be, as Brian said, they're cohorted once they get to Heritage.
But they're cohorted by school, or they're cohorted by the classroom that they're in the school that they came to?
Thought it was both.
Well, right now, I would say the numbers are not going to permit separation by grade in school unless there's a drastic increase in the.
We're talking like we're like 30 kids right now. It's pretty low. So we've got some conversations to see where that's at.
If you're
For these kind of things, I think it's a PPE works, it's a huge trial in these things, but I don't think it's a deal breaker.
Yeah.
Right.
Does that make sense?
Yeah.
I don't know if you guys are.
Yeah, can you say that
I couldn't
again?
hear you.
So for these kind of things where you might have one kid from Prairie, but three are not bringing them on the same bus, if they're wearing the PPE, so they're masked,
Yeah.
they're distanced, it's good to try to do those things, completely isolate those things, take away all that risk. But I don't feel all that uncomfortable with the PPE in place with that being a deal breaker. I think it's okay to do those things. You shouldn't try to do that or not paying attention to it. But I think, logistically there's some things you can do, some things you can't. If they're wearing PPE, our experience is that it's very effective. And I wouldn't be too worried about, my kids being on a bus to go to after-school care with some kids from another school as long as they're past a distance.
But yeah, if they're first graders, they're challenged. If we have them in the office, they'll wear it, they put it down, they put it back on, and wander around. And they're everywhere. And you can't really blame them. I don't think you can.
Yeah.
That's gonna be very difficult, unless you staple it on.
It's a question if the school, so if you have kids from Heritage, kids from Arboretum in the same after-school care program, and Heritage is closed and Arboretum is open, do the kids in the that are going to after-school program from Heritage still come at that point?
Not if they're,
So
not
we're
if they're
just
in a class that's quarantined, right?
Right, so they wouldn't be. So I agree. I mean, if that's the only place is in that transport, and mixing, and
The slight incremental risk there is not enough to do this program.
And again, we're gonna try to do our best to keep social
Right.
distancing on the bus as well, so.
But she did say, like, what happens if you do get a couple cases in that group? That's gonna be a problem. I mean, if they're-
then the other kids are going to be quarantining too.
Right, you have the spiral, I mean, it's
Yeah.
a spike, the spiral spike. I mean, that is that's why if I was trying, and I know it's an ideal world thing, it's like, hey, I would like you to stay in your building. I mean, if you would leave your building. I don't know if that's feasible or possible.
I don't think it's legit, well, that was our hope to set up, but it became impossible to make happen for the for the program that was going to deliver it. And then ultimately, even if we had the care program that was able to deliver it, at the use or the number of kids that have signed up to do it now, we wouldn't be able to staff it. They wouldn't be able to staff it. So we're at a single, we have to be at a single site with blended rooms just to get it to operate.
That's it. But she was saying, I think that would produce a high alert. I mean, if there's a kid that turns out positive in that, or a teacher, that's gonna be a high alert problem.
Yeah, I mean, think about what are the triggers, right? It could be the percentage. It could be a particular set of kids who are in, dispersed.
Kids that are spiraling to other places, that's an easy, like, then you have to decide differently. Yeah.
Is that something we need to work with the other daycare providers in Waunakee? Because they're not, all the kids who are gonna be in K2 for the other half of their daycare aren't gonna necessarily be in the one with us. They could easily go to any of the other daycare providers. How do we let them know so that they don't spiral it on us? They could in effect do it and we would have no idea.
And there's also some of the daycares in town are not accepting other kids. So they're not all accepting kids that are coming out of the school through the wrapper.
But the ones that do, maybe we need to set up some sort of protocol for how we help them keep from doing what we need to keep from doing with the daycare we have.
The other piece of it is providing the training and education to the staff members of the daycare program, just like we're providing for our staff. I mean, I know that they have to follow public health guidelines, but we might want to just ask them to look at their training and education materials, and if they want us to do something, we can do that.
Yeah, they'd be very happy to, I'm sure, share that, and we can make sure that it's congruent with what we're doing.
So I apologize again, do you have a daily group? I mean, that's like a COVID group, like, we have a COVID group at our clinic, even at the little clinic. Do you guys have that set?
You're looking at two of them.
Every day? Well, it just has to happen, I mean, that's how it has to be.
Yeah, we touch base, actually, right now, it's multiple times a day, even though Sarah's only a 50% person, she's worked well over 50% this summer. We also have a spreadsheet that we're keeping track, as we hear about students or staff, we're keeping track of student, grade, building, et cetera. If they tested positive or were a close contact or whatever the situation is, and then our steps, our actions of you're not coming to school for 14 days, et cetera. And then we have, various follow-up points. And then if we do get to that, where now we have a whole class, for example, we'll add the whole class to that list and continue to monitor and track that as well, so that we're managing all of those things until we can clear a student off or a staff member off. So we have a spreadsheet and we're monitoring that all in so that we can hopefully keep track of who's where in the process and cleared, ultimately cleared.
I teach at Whitewater and I just got an email yesterday about their COVID stuff. I'm assuming it's a UW system where they send out the data once a week about their campus. You haven't seen that?
Trying to do like weekly dashboard.
Yeah, it's a weekly dashboard that says how many faculty, students since March have had it and recovered and stuff like that. I don't know if that's something that not necessarily has to go out to the public, but it'd be nice to have some of that data.
Well, I think we've basically covered the concept of metrics. It sounds like we're either going to get the fast one from Dane County, or ours is not going to really be a hard number, but more of a staffing issue and a concept that Randy's basically going to have to deal with on the fly. I think you're right, though. Dane County will probably hit us first if we start looking really bad. They'll see the numbers and the spread faster than we
And it
will.
might not even be you that has to look at it.
Yeah.
The district might be, they may just be the county.
Or that spreadsheet's gonna get really long and you're gonna, Kurt's gonna call Randy and say, hey, I got a problem.
There's no discussion to remove the campus from those numbers. Dane County, that they wouldn't.
I think the tricky thing for Dane County is like, I don't know that they have that kind of resolution where they can say, and they've got some heat maps, and I can tell you like cases around Waunakee, but I think it's gonna be hard to say. And plus there's intermingling, right? Like these kids that are on campus live in Waunakee and Middleton and everywhere else too. So it gets hard to get those micro geographical areas and feel confident that those are safe, but other areas, 3 miles away are not.
Right, yeah.
Well, then, the last thing I personally put on the agenda was about rapid testing for staff and students. That was what we've been talking with Dr. Wald about for the past couple of weeks. She did drop off the call, and she said Dr. Potoff and Dr. Anderson are now totally responsible. But she will talk with us later more if we need more help from her. So everything most of the public has heard is the big solution to this is testing and rapid testing. I had the good fortune to talk to Dr. O'Connor, David O'Connor, a little bit about his testing and what he's been doing with the Fitchburg School. And he said for $5,000 he could set up our district at $5 a test to run that spit testing, and basically use that as a screening model is what they're doing in Fitchburg right now. And they basically test everybody twice a week. You do the test yourself. You collect the samples and you can run the tests. Any person can pretty much, he said, process about 100 tests a day with the $5,000 initial setup of the equipment. And that's what he's got a school in Fitchburg that they've been running for their model for now. So if we were, he suggested twice a week testing of everyone. And then that way, if they get a positive result on that, you then go for the full test, because it's not a diagnostic test. But it does say if the testing basically tells you if they're symptomatic or they have things that would indicate they may be symptomatic. But it gets them before they become symptomatic, which is the big advantage. I don't know how much you guys know about his test or have seen anything of it, but
that's the question, is to understand that test. So a test that only has a $5,000 startup cost and $5 a test doesn't sound like it could be a very good test. It certainly isn't a PCR-based test, even if you're using saliva. It might be an immunoassay using like a fluorescence type thing. You want to make sure that the sensitivity of the test is good enough such that those kids that are negative are actually negative, or you're not really moving yourself forward.
Yeah, the reviews I got on the spit testing right now, the sensitivity is not very good. I don't know. Maybe some of the tests are.
I think the sensitivity on some of the testing is fair. I think, you hear about the Yale NBA, collaborative, but to Jeff's point, that's a cheap test, but it's not a cheap platform to buy. If you buy, so it would be way more than $5,000 to buy the machine that the test runs on. So I think there'd be a lot of questions about what's the sensitivity and specificity, or more of the sensitivity, of that test to make sure it's worth, the effort and the trouble to go through to do twice a week. Most of these tests require a decent amount of spit, so it's not just like, one time. I mean, so it's, you have to be sure that it's worth it, I think. And so if there are any specifics on the tests, I think that would be important.
I think it was the NFL that just went through the spate of the false positive problem.
Right.
Right, and so if somebody has a false positive test, that does a lot of damage also.
Right, the mental well-being piece of having a false positive and now thinking I've
NFL just
exposed
went
all these
through
other
this,
people.
And I don't know, I feel like 177 or something positive.
That was lab handling error, but I think, what we can't have is if it only catches 6 out of 10 kids, that means you let 4 kids through, but you might start feeling a little bit more confident, because everyone's testing negative, so just understand the performance of that test, but, if it's really.
Hang on a second. Aaron, you had a question?
Yeah. So, like, what level of specificity were we talking about that would be worth it? Like, I'm looking for a level from, okay to snake oil. Like, what percentage are we looking at?
What percent sensitivity?
Sensitivity.
I'd throw a number out there, but I'd say in asymptomatic people, so not tested in people who've got all the symptoms, because that's not who you're using it in. Asymptomatic people, you want to see a sensitivity of at least 85%.
Yeah, that's it.
I didn't get any numbers like that. He just said it's the RT lamp method, if that means anything.
But I think that's fluorescent.
There's one test out there now, I forget the company, and they have got pretty good sensitivity specificity in symptomatic people, and it's doing a different type of test that's cheaper to do, but it's not very well proven in asymptomatic. That's much harder group to test in because their viral loads are typically much lower, so your test has to be even better to do these screening of people who you don't think have the disease. So it can be a little bit tricky. Let's just leave it at that.
I think it speaks to what's the equipment that goes into it and what are the quality controls that you have to do and who's going to do that, from a district standpoint. And so it seems like a more quality test is going to require some of those things, and those might not be competencies that the district has or really wants to handle. And, if you think about other liability pieces potentially with that.
I would be concerned with your liability, send somebody with a false negative home or a false.
I guess the other piece of it, because I think what Dave you're talking about is trying to have some sort of a screener that gives you a level of comfort to bring people in. The other piece that I think is what's the availability of rapid turnaround testing when you have a class that gets quarantined, and then making sure that teacher or that kid who was symptomatic, and then we're not overly quarantining kids for 14 days, but trying to get them back, and how do we the accessibility to them, particularly with kids who not only have access to health care, insurance, etc., but those of our kids who do not have adequate
access to transportation, because some of the kids would not be able to get to the testing.
Right. So if we had a kid like that didn't have transportation pieces, are there things within our own community that is there a place that they can go?
Right now, I'd say no, because we aren't even doing the testing at our site yet because of the time problems. I mean, you go to West, you get it at our sites. You go to West, the lab can get it done.
So at D and Waunakee, the testing doesn't.
Right now, as it sits today, again, everything changes every day with COVID, at least in my world. I've not had 2 days the same, so I'm waiting. But I would hope that at some point there's local testing. I mean, I'm sure that at some point it'll be strep testing type thing where you're just doing antibody responses.
I think of there's surveillance testing, which is what we're just talking about, and there's diagnostic testing, which is I think someone has that I could diagnose it. It might be hard to do as a single school district, but I think as we look at Dane County school districts in general, it might be reasonable to start talking about public health to see if you set up some sort of process with Alliant, whoever's running that National Guard versus Dane County Guards and Public Health to say, how can we identify and to make it easy for kids to get tests? Part of that, one of the big things would that be to collect it in the school for those kids who don't have transportation, don't have regular. If we let them go home, it's really unlikely that they're going to get tests. But that reduces the number of kids you got to do because most of them are going to have a primary care doctor. They go through the normal health systems to get their test. Is there a way to collect tests, courier it over through either to Alliant or through Exact Sciences or some of the labs that they're working with, and get those test results back for those kids or those families who otherwise don't have a way to get testing, so that you get them back in school quicker. That would be a long, complicated process, but that would be worthwhile if we could get that. And rapid testing, same 24 hours. You get the result back in 24 hours. Kids miss 1 or 2 days of school. the school knows within 1 or 2 days whether they got a problem or not, that would be pretty cool but hard to do.
That's, I mean, you almost have to have a team of people working on it, I mean, to keep track of those people.
Maybe a good place for us to start is with the conversation about public health, of how they could expedite access to kids to get tested as they're in these different situations.
Or if we find that we have an outbreak in school, you know, we're hearing on the calls that they're putting pop-up testing sites in certain places. It may be
Yep.
that if we had an outbreak here, that would be a time that they would consider doing that.
But then you wouldn't have school. I mean, it sort of gets to be this whole circle.
Well, it gets to be a little bit about, you're looking.
Get back to school quicker.
Right, you have to do the testing.
Right,
But you wouldn't
campus
be-
is developing like mobile, so they've got, you know, an RV that can go to whatever
Right.
site. It's possible that the county could figure out a van that then brings testing to the school or goes around and figure that out.
I mean, it seems like there are a couple different pieces to that, right? One is just surveillance testing as a routine. Like so talking public health, how many people do we need to do, you know, to kind of feel comfortable? How would we maybe get that done? Another piece is testing asymptomatic students who are in a quarantine status in order to get them back, because the health systems are going to have difficulty doing a lot of asymptomatic testing just because of an exposure. And then the symptomatic ones really is where the health systems come in and support you in doing that. So it seems like the conversation with public health is in a not a quarantine situation, you know, how many, you know, could we do? Maybe they could offer you a limited number of tests that you would say, okay, we're going to pick 30 kids, you know, this many days a week instead of having to do everybody. And then, you know, what do we do if all of a sudden we have 2 rooms that are quarantined, but we're not shutting down the building? How can we get those kids tested? Right now it's Alliant, you know, but maybe there's a different, you know, model where they come out and do something mobile on a pop-up, you know, for that.
Though, it gets to be the circle of, it gets to be a circle problem, because the false positives then will count into the positives, right? So if I do a certain number of tests, I will get a certain number of false positives, no matter what.
Well, I mean, if they're using I guess it depends what test method they're utilizing. So if the county's coming out and the public health is doing, you know, a nasal or nasopharyngeal swab, that's a different, you know, for those kids who are in a quarantine, that's going to be a lot better than doing a salivary.
Mm-hmm.
It depends what their turnaround time is going to be.
Where are you going to count the positives? It gets to be really messy, right? Like, where are we counting positives?
And if we were to do it that way, parents would need to be here to support their kid during a nasopharyngeal swab. That would be just something that we would
And you have to have consent.
you know, without, it's not I wouldn't call it an invasive procedure, but it's
Right,
not
it's not
something
pleasant.
that we're just going to do
But
on kids.
but you were talking about that more as a surveillance testing of having like 30 per
Oh.
whatever time frame window.
I think
Every
actually
so often, we could schedule them ahead of time. The problem is that you know there's going to be some parents who are going to say no, and we have to find a way to ID that.
The surveillance testing, you know, I actually think the trickiest one is the exposed but asymptomatic group. I think that's the trickiest group to think about. I think the just kind of routine surveillance testing, it doesn't matter if some people opt out as much because, you know, you just need a small number anyway. It's, you know, kind of get to the point that Jeff talked about earlier where you have a class that needs to be quarantined. And then it does come to the parent, though, at that point. How do we make testing available, you know, to get those kids back to school? And if the parent chooses not to, then the kid's not going to be in school until they're into the quarantine, and that'll be their choice.
Somehow to get that available, so, I mean, that would provide benefit to the kid. If you say you choose not to do it, that's your choice, but it is really hard to get it done locally right now.
But that's right, that's the hardest piece, because we're going to be asymptomatic, so the health systems aren't going to have the capacity to do that. It is really going to be a conversation with public health to say, hey, we had a positive in our class, we want to get our kids back, we don't want them out for 10 days. How do we in 2 days get all the rest of the kids in this class tested quickly so that kids are out for 3 days instead of 10? That is probably the hardest.
It's probably a very valuable question to ask public health and just collaborate around, which isn't going to be unique to Waunakee, obviously, either.
That's a system problem. That would be a great system. Those pop-ups would be great.
The other piece of that, I think, that has to work in order for us to be able to consider doing something like that is really monitoring our social distancing that's happening in the classroom.
Mm-hmm.
Because if that works fine if your exposure is just that, it's an exposure, but it's not a close contact. Because even if you're a close contact and you have a negative test, you still have to be quarantined for those 14 days because you could develop symptoms during that time. So for people who've had that 15 minutes or greater exposure, you know, hopefully in the classroom it's not happening, but I feel like in a way, at least in the beginning of this, there needs to be a formal method of assessing how well we're actually socially distancing in our classrooms and how much of that mixing is happening.
A self-audit process, kind of. I think it's the other thing is just stressing for the teachers that it's okay to say if social distancing didn't totally occur in your classroom yesterday.
Yeah.
You know, I think there's going to be that piece too of sort of judgment that if my principal asks me, you know, we have a positive, principal says, did I, you know, was my class socially distanced? And if I say no, then like now I'm going to get in trouble. You know, I think it's just important to really stress that as well.
That's gonna happen.
Because they're going to feel judged or embarrassed if they weren't able.
We need to document it when it does happen so that we know that like that day, that class, you know, those are close contacts in those classes.
I mean, you could even anonymously self-report, right? You could start off and say, you know, how frequently do you think that people are staying 6 feet apart, and just have it like be an anonymous survey monkey or something, and get a sense for, you know, what's truly happening.
Distancing, it can't be a punitive approach, or people are going to stop telling the truth when you ask them, and then you're not going to be able to get on top of this stuff.
Which is already happening.
Yeah, it's going to happen as far as like we're going to have breaks in it. Not great, it happens. We need to understand that way, whether you tell us about it. We can help you figure out how we fix those gaps, but no one really should be in trouble.
Yeah, we've had a few episodes at our clinic where people said, any of did the questions, and then they knew their test was already in, and they were positive, right? And they didn't know they were positive at the time, but that was what made the 4-day gaps. Now we're down to 1-day gaps. So people like, I didn't know exposure, no risk, no nothing. Oh yeah, and I had a positive test.
Yeah.
You know, show up 2 days later.
One follow-up for public health, are they giving you close contact, needs to be without a mask, or even with a mask, they're going to count that as a close contact?
Even with
But even with the mask and 6 feet apart, you're okay, or?
Yeah, so mask and 6 feet apart.
Greater than 6 feet.
Greater than 6 feet
Greater
for
than 6 feet. And then 15 minutes.
15 minutes, yeah.
And a 24-hour period. So if you have 5 minutes of contact.
Yeah, so I mean, if you can feel pretty confident that your teachers, you know, are being honest with you about, you know, the amount of distancing that's occurring in the class, you know, it may be that you don't have to shut down, you know, as many people. It's really going to come down to that question of how consistently is that happening in the classroom.
Do all the healthcare professionals have our scenarios? If this happens, here's our 18 or whatever they are.
At some point, but it was a long time ago.
That was a while ago. Yeah, we haven't sent
They're
those
the
out.
same.
Really, those scenarios seemed mostly to help guide when people come back, is what I thought. It was really the intention of them. So
It was a lot about who can be here, who can't.
Right.
Yeah, and there's not 17 separate ones. I just grouped them that there's like 9
David, get this something from
9
like 30
staff
seconds.
related ones, and then 8 or so student related ones. There's repeat language in there, but what I did, that the documents that I took it from didn't include was the third column on the right, which is what happens to everybody else. Because the documents themselves just talk about the person who's either the close contact or test positive or negative or asymptomatic. I added the third column of, okay, now what happens to everybody else because of that first part.
Okay, Aaron, you had a question or something? Comment?
Oh yeah, I just wanted to follow on to the thing about the teachers reporting honestly. That it would be important also for teachers to not feel pressured by administration or anyone else above them to avoid saying things that would shut down a classroom or a school. You know, take responses in 13 seconds.
I think that's definitely part of the honesty part, is not feeling that there's going to be some form of retaliation or some form of judgment, I think was another word used.
I think it's just about having a
based on
culture
it.
of safety, you know, and knowing that being honest is keeping everybody safe, and even if it's not the quote-unquote right answer, you know, the safest thing is just to be honest.
It's the real answer.
Yeah.
You message that,
Yes.
and you'll see it when people do it, and they're congratulated for saying something instead of crushed, which is, I mean, then you'll build that safety culture, and it'll be fun.
Valerie?
Yes. In addition, please remember that currently the students who will be coming in are developmental level of the students who are coming in that you're asking to social distance.
I think that message of, we know there are going to be gaps, we know that things aren't going to work, just we need to know about them when they are and what can we do to support them, and, there's going to be a failure rate, undoubtedly.
And that 15 minutes isn't, a high five or a handshake, that's close contact too. Or if,
Yeah.
you.
Physical touch.
Those
Right.
physical touches are close contacts, and how many times will that occur in a classroom? So are we really safe to say in the 4Ks and the kindergartens that if we had a model of social distancing, we can say that it's a model, are we safe to say that we won't quarantine that class?
No, I think that's an excellent point, because if you find that you are having breaks and they're hugging and all that other stuff, well, then we have close contact, and it makes sense to quarantine that class.
Right.
As you get into older grade levels, maybe you do get to a situation where like, no, we're good, but those younger grade levels, when you talk to teachers, I wouldn't be surprised if they say, yeah, like kids are all over each other, quarantine that class.
So, just to recap, when we're getting onto the testing issue, it seems like probably our main focus should be on the asymptomatic testing, trying to find a way to get our students tested as quickly as possible so they can get back into the classroom sooner, and our staff. And the problem there is about the resource of being able to get the testing done.
Asymptomatic exposure.
And
Exposed asymptomatic.
Asymptomatic close contact.
Right.
So they have no symptoms, but they're pretty high risk. You gotta get them tested before you let
With a reasonably sensitive test.
Because they probably won't be able to get that from their primary most times, or won't be
They're
covered.
asymptomatic, yeah.
Maybe. I mean, if there's a really good risk, there's a chance that that'll be able to happen, but I wouldn't count on the house.
Not on a broad, across the board kind of.
Not the sort we want.
Right.
So we can talk with Dane County Health about it. I have been in talks with Conway,
Jim
owner of
Conway.
Exact Sciences.
Oh, Kevin.
Luckily, he happens to know someone I know. His problem is he's under contract right now, and he doesn't have any extra capacity, but he's building capacity, and he does want to help schools. So maybe in the near future we'll be getting there, but not right now. The biggest problem is the reagent, that is a short supply.
Yep.
So.
And that's nationwide problem.
And that was one thing, Dr. Wald was the biggest reason, I think he got us in touch with her, and it's the biggest thing she's been trying, and she's having no luck. So hopefully it'll get developed over time, but it's probably going to be the biggest thing we're going to look for. And I'm getting the feeling that the concept of some sort of screening testing, most of them just aren't reliable enough to be worthwhile at this point.
Not unless you're gonna put them in a bubble.
I think if they are, they require the reagents that are in short supply that our labs, SSM, UW, everybody is trying to get. So then you're competing against, health systems with pre-existing, contractual relationships, and everybody's trying to get the same reagents.
Sick people.
And you could potentially pull away the ability to test people who need testing more than symptomatics just to do surveillance, which that would be moving in that direction too.
Okay, so I think that told us where we need to look on one issue. And kind of brings us almost back to the first point. Okay, what have we missed? The idea of what this committee also should be looking at, other than just the couple we had so far. What areas should we be concerned about that we haven't discussed?
I think we covered it pretty well. I mean, I wrote down at the beginning when you mentioned that, so you think about face coverings, you think about physical distancing, you think about how you're screening, you think about how you're handling symptomatic, people, you're thinking about, what your triggers are going to be for different actions. I mean, that's the list that I had jotted down at the beginning. I don't know if anybody else had other things, but yep.
Your staff are probably going to ask you how long they're supposed to use their PPE for. So that might be, that's a small point, but usually anywhere between like 3 days and 7 days, and then get rid of it if it breaks or is contaminated would be advice to get them. They might be able to store their PPE. I wouldn't be surprised if teachers are like, at my school PPE that I keep in school, typically in the health systems we use a breathable container like a paper bag, and then they'll have maybe a separate face mask for use to leave the building, just so like they're bringing their school PPE home. That would be a small thing to consider, but these are all like just minutiae things. assume you have a plan for, you're an hour into your block, and also your teacher's got to be able to how to get that teacher out and keep that class going. I don't need another plan, but I assume that you got one.
Kurt's nodding, that's a good sign.
It's called principal.
Or the school nurse.
And if everyone goes on, Randy, or?
I think the other thing I
can get there.
No, those are small things that I was trying to think of as we talk.
You have to expect something will change. Nothing, I mean, my days, I'm sure yours the same, nothing has ever been the same. So all the things we say, when I talk to
Everything
people,
stays status quo. doesn't
yeah,
it?
they will change.
Friday was a mirage.
I know, it's just
Yeah.
going to change. So part of the expectations of our group now is that it will change. The rules will change. We don't know how it's going to change, but they'll change. Because you can say, teachers particularly like 5, they're great, they like their rules. It's like, well, these rules could change tomorrow, right? We find something different, so.
The other thing I was going to just mention is if you want to add something on the screening sheet about testing and people who have tests pending or have been exposed, thinking about testing and exposure questions being added to this, just because I think that could be helpful in identifying people who are going to be positive.
Adding it after a failure.
The other piece is, flu vaccine and just how you're offering that, I think, for your employees, but also, for the kiddos. And obviously that's a loaded topic, but, if you think about influenza in a good year, maybe like a non-COVID year, can certainly run through a school really quickly. And if you think about all the implications for that compared to, now you have people with fevers and coughs, and think about the strain that could place on your resources. Just having an open dialogue and conversation about flu vaccination, especially with your employee group, but then obviously, we're trying to communicate that, to the public as well. Just something to be considerate of as you're going forward, because it could really wreak havoc if, hopefully we'll have like the Southern Hemisphere and people will be distancing and masking and we'll have less flu, but it's still an important point.
We'll knock this out. That didn't really happen either.
Yeah.
I have one question, I guess. All of our staff are experiencing various levels of anxiety, in regards to returning and working with this unknown that we have. Just, if you could just share from your own personal experiences or what you've done as an organization, and I know you're not representing them, but how did that all unfold? Is this, I'm sure your staff and even you experienced that anxiety of not knowing, and do I go to work, and help us kind of work through that, because that, I think, rightfully so, is a huge factor in all of us as we're approaching this.
Mine was just what I said from the beginning. It's like, if you wear the stuff on our primary floor, these people are constantly exposed to it. They wear the gear. They have not gotten it. Now, I can't guarantee anybody that. But the people who work with it, the nurses and the staff that work with it every day that wear the gear have not developed any. And no one has got infected, which is, to me, amazing. Right? So, but that means they have to wear it. I mean, so that's my reassurance, is you wear it. If you do the right things, it seems to work.
I agree. There's fidelity to appropriate PPE. People do really well. Not zero risk, but very low risk.
Very low risk if you do.
PPE and distancing. So I think that's been our experience. And then I think it's just about that culture of safety and, creating those opportunities for open dialogue and support for people being stressed out and, a lot of the uncertainty. And so, whether that's EAP and other, resources, or those are huddles and people just having open dialogue about what they're, concerned about. Obviously the health systems are here to support, people who are in our practices as well. But I think the more you can do to reassure that the PPE works and then just offer those other opportunities for people to have dialogue.
Yeah, that would be my one. The PPE works. You just have to do it, right? It does work.
So I think what anxiety is because I think something bad's going to happen. I don't have any control over it, and that's not the narrative here. If you use the PPE the way that the district's going to provide it, we all think it's adequate. You're in control. If you do that and you maintain that, the chances of getting sick is really small, and it's inevitable on your court. You've got control over it. And healthcare has been doing it now for months, and we've got good data on it, like it works.
It works.
I think the other thing though too is just the fear of being positive and having shame. You know, if I get COVID, that I'm ashamed now because of this and I'm going to be viewed. And I think just having that, again, open conversation about, you know, somebody's going to get it, right? It's going to happen. And it's not because you did necessarily anything wrong. It's not because, you know, even though we say the PPE works, there are times where there's something else, who knows where you got it from, right? I think making that culture of safety and, you know, just upfront, because sometimes people are more afraid about how other people will view them if they get infected, or the fact that they might cause physical, you know, challenge or stress to somebody else. Almost more of that than they are about themselves. So I think that's an important part to, you know, just have that conversation with your staff as well, that set the expectation almost, somebody probably is going to get COVID and we're going to support you, and that's not something that you need to be ashamed of if it happens.
Yeah, you're way better off reporting that you have it, or reporting that you have symptoms, than dealing with the consequences afterwards.
And it doesn't mean that you got it, you know, at school, you know, it's just, it's a challenging conversation to have, but I'm almost struck by how people, you know, at work can be, in other places, can get really paranoid about not so much just getting it, but what is somebody else going to think of me if I do get it?
And I can share, I've been working in the hospital since March with a lot of staff, a lot of patients, and I remember back in March when I was, you know, being told our new policies, procedures, I was terrified. And I can tell you, I felt just, I wanted to be at home. I felt safe there in that environment that I could control. Now I can tell you, I feel really safe at work because it's proven that the PPE works, and with everybody masked, we have remained healthy. And now I feel more anxiety going to the grocery store than I do actually going to the hospital. So I echo what everyone else said, that if you wear your PPE, you really will be safe. It's definitely played out for me since March.
And it's definitely dangerous at the grocery store because nobody can follow an arrow. It's impossible.
So the last thing on that is just like over-communicate, like really let your staff know why you have the policy that you have, how you're keeping them safe, how they can raise concerns to you. Just, they really need to feel like leadership is being transparent and has their best interests at heart. And the best way to do that is just communicate, being transparent, let them know.
So do you guys have safety, you had safety meetings at each building now?
Yeah, so what we did was we sent out the PowerPoint with audio behind it and had them watch it individually. Then we did an overview and a question and answer for each building.
Sometimes, like, to the point, like asking anonymous questions or whatever, it seems to pull it out. Ours, the people tag behind us and our staff are like, what is this?
They're like yeah, and we definitely have been open to say, if you think of anything after these meetings, email Kurt or me or Jenny.
Yep, no, that's it.
Well, I think we've gotten towards an end here. But my thought is, you guys are right, this is going to change constantly. And if you don't mind, I wonder if we could set up another meeting maybe in 2 weeks. Only because, one, I know Kurt was talking about your scenarios you have and everything. Maybe, I don't know if you've all seen them or not. It might be helpful to review those at a point, and then by then you'll have a week of exposure to it. And if we have problems, maybe we could see how we might be able to better handle them.
Why don't we do it in 3 weeks, because we get a soft start, right?
And we really don't have kids back to the 8th.
They're back until the 8th.
Yeah.
Oh yeah, because that would put us right in the week of the 8th, maybe the week after that.
So that way, you know, give it a week in classes, or maybe 2 weeks in classes, and kind of come back together and say, okay, how's it work? You know, what are the chinks in the armor that need to be fixed at that time? So you're probably towards the end of September, I would suspect.
Well, if the first week of classes are really fully the 8th, you'd be looking at
that next week.
the week of the 6th, the week of the 14th, which it's Wednesday. Would Wednesday the 16th, same time work? Would that seem reasonable?
So I'm not sure you get enough runway as to, you know, what are we seeing?
So if you go further out, then you have to have a rapid response, right? which we've done in other things, where you just
Right.
have 4 or 5 people that you can deal with, or you can deal with at a high level, but I don't mind going further out, but I think my experience with it is that something always happens, you know, that we don't expect. Not that a whole group meeting has to happen, but.
Well, that's why we have, what, 10 school board meetings in a row per week right now, because something is always happening.
I like the 16th because it gives us a week with the kids, with the staff in, and then we can come back. and
I'm
do
sure
something.
you'll hit multiple scenarios by.
Oh, yeah.
We've already kind of worked through it.
We've worked through some of them already.
Let's, if you don't mind, let's set it for the 16th then at 5:30, same setup, and let's pray the sky doesn't fall by then. And let's pray it gets really sunny and all the UW students are the most responsible people in America.
Yeah.
Um,
Hmm?
You do the 16th? I can't do the 16th.
Yeah.
You can, it doesn't matter.
Yeah, I'm here. I think so. Unless my wife tells me otherwise.
That's how it works.
Well, I really want to thank everyone for coming. I mean, I know you guys are swamped with this stuff as it is, and we're just a small part. But it's great that you all live here in Waunakee and have a great desire to help us keep it open. So hopefully we'll be able to. So motion to adjourn?
So moved.
And there's a second.
Yep.
And all those in favor say aye. Thank you so much.
Yeah, thanks, guys. Randy, good to see you.
Good to see you.
Nice to meet you.
Just gonna let you